Welcome. Good morning, everyone. This is the STI Clinical Update with the San Francisco Department of Public Health and the California Prevention Training Center. We're so excited to have you here with us today. Traditionally, we have this as an in-person annual event, but we have not had our City Clinic STI Clinical Update since February 2018, so this is an exciting event for us today. My name is Allison Decker, and I'm a nurse practitioner with the San Francisco Department of Public Health. San Francisco City Clinic, which is part of Disease Prevention and Control Branch. And this is the STI Clinical Update half-day webinar, and this webinar is being offered jointly by the California Prevention Training Center and the San Francisco Department of Public Health. Today's webinar is scheduled from 9 a.m. until 1 p.m. with a 10-minute break at 10:40 a.m. And this webinar will include a talk with Dr. Stephanie Cohen, STD Controller of San Francisco and Medical Director of City Clinic. She will be covering San Francisco STI epidemiology and program updates, followed by a deep dive into syphilis with Dr. Kelly Johnson from the California Department of Public Health. After returning from a short break, we'll hear about important updates to the newly released CDC STI Treatment Guidelines with Dr. Aina Park, Medical Director of the California Pacific Training Center and author of our favorite sexual health book, Strange Bedfellows. And we'll close today's webinar with a lively case panel brought to you by Dr. Oliver Bacon, lead physician at City Clinic nurse practitioner extraordinaires, Yvonne Piper and Terry Marcotte, and our physician guests from University of Washington, Dr. Meena Ramchandani. A little bit about the California Pacific Training Center. The California PTC is a multidisciplinary training and capacity building assistance center. They are sponsored by the CDC and a member of the National Network of STD Clinician Prevention Training Centers, which runs the STD Clinical Consultation Network. This is the regional map of the NNPTCs. The California PTC covers California, Nevada, New Mexico, Arizona, Hawaii, and Guam. And you can see the other prevention training centers here. So if you have colleagues in another state, you can refer them to the NNPTC or their local prevention training center. The California PTC also runs the STD Clinical Consultation Network. This is an online clinical consultation network that you can submit complex STI questions to, and a subject matter expert will reply either by phone or by email per your request within 1 to 5 business days. Here is the California PTC financial disclosure. And here is the California PTC CME disclosure. Regarding continuing medical education requirements for today's webinar, CME will be given to those who registered for the course on NNPTC, and you need to stick with us for the full webinar today. So this webinar has to be watched live and it has to be watched full in order to receive the 3.75 units of CME. And unfortunately, the PTC can't give CME credit to those who are viewing a recording of this webinar or give partial credit for viewing a portion of the webinar today. Attendance will be noted as attendees sign in. After that, you'll complete a post-course survey evaluation, which needs to be completed by November 12th. You will receive a link to that evaluation from elizabeth.olson@ucsf.edu within 24 hours after the webinar has ended today. So that's the email address to keep an eye out for. Sometimes it goes to spam or junk. So if you haven't received it in 24 hours, then check those folders as well. In terms of processing, the provider is University of Nevada, Reno. Your CME notification should come in 4 to 6 weeks, and that's how long the processing time takes. If you meet the CME requirements, you'll receive a notification from captc@ucsf.edu with a link to claim your certificate. So to make sure that you receive that, since it can also go to your spam or junk folder, you need to add captc@ucsf.edu to your safe or trusted senders. Regarding post-webinar materials, in 2 weeks processing time, you should receive a post-webinar materials email notification, again from captc@ucsf.edu, that will include a copy of the presentation slides, an access link to the webinar recording, and any other course materials from today's webinar. A couple quick housekeeping rules about Zoom. We will have speakers, microphones, and videos turned off during the webinar, except for the panelists. Chat will also be turned off. and the Q&A will be turned on. So if you have questions that come up, please enter them in the Q&A. The way that you do that is you click on this icon that you can find at the bottom, which will open the Q&A chat window, and you type your question and send. If you want to send anonymously, then you can select anonymous. You can submit questions up until the last 2 minutes of each speaker's Q&A section. And we'll be reviewing Q&A after each speaker's talk, as opposed to at the very end of the webinar. The questions from the attendees will either be answered directly in the Q&A chat window or live during the Q&A session. And we will also send out a document addressing all unanswered questions that will be included in the post-webinar materials. Administrative questions will be answered by those helping to coordinate the webinar. If you have any questions, you can reach out to Elizabeth Olson, who is the CAPTC Clinical Program Manager, and her email is here. Before we get started with today's talks, I wanted to let you know about some important sexual health resources from the San Francisco Department of Public Health. First, I'd like to introduce you to the new City Clinic website, which has dedicated resources for both patients and providers. On our website, you can find important updates regarding STI screening and treatment, information about our services, materials for your patients, and our new blog. On our provider page, you can also find our citywide STI screening guidelines and 2021 SF City Clinic clinical protocols. The revised clinical protocols incorporate all relevant updates from the new CDC guidelines. And as you'll be hearing about later this morning, there are a lot of significant changes in the STI treatment regimens. These SFCC clinical protocols are a concise, user-friendly accompaniment to the CDC guidelines, and they are also available on the CHN intranet. If you like what you're hearing about today and you're interested in bringing it back to your clinical setting, I'm available to provide consultation, training assistance, and capacity billing to providers and clinics. Here you can see some of our provider materials covering everything from syphilis to PrEP to rapid ART initiation. If you're interested in learning more, please reach out to me directly at allison.decker@sfdph.org. And if you haven't gotten enough STI updates after today, the National STD Curriculum is another fantastic resource on STIs. You can earn MOC and CME by completing self-study exams. And lastly, if you're a true STI fan, you must pick up Strange Bedfellows. This hilarious and fascinating book blends science and storytelling to explore the history of STIs and their impact on our society. And we are so pleased that the author of this book, Ina Park, is one of our speakers today. And lastly, I want to guide you on how to sign up to receive San Francisco Department of Public Health health alerts. The city sends out health alerts to notify providers about important updates that affect our community and clinical care. In order to receive these health alerts, go to www.sfcdcp.org, select Health Alerts and Emergencies, scroll down to Health Alerts, and then sign up for health alerts to enter your confidential information. And with that, it is my great honor to introduce Dr. Stephanie Cohen. Dr. Stephanie Cohen is the STD controller for San Francisco and the medical director of San Francisco City Clinic. She is an assistant professor at the University of California, San Francisco in the Division of Infectious Diseases and an HIV primary care provider. Her research focuses on using implementation science to guide the translation of STI and HIV prevention research into clinical and public health practice. She is currently site PI for a randomized control study of doxycycline PEP to prevent STIs. She's a passionate advocate for PrEP and loves to talk about syphilis. And I will now turn it over to you, Stephanie.
Thank you so much, Allison, for that fabulous introduction. Good morning, everyone. We're so excited to be here with you today. As Allison said, this is our first annual STI update in several years, and we have a lot of great content, a fabulous lineup of speakers, and really are thrilled to have the opportunity to share with you a lot of important information about sexual health and STIs in San Francisco. I'm going to start by providing some updates on HIV and STI epidemiology. I'll talk about some of our program activities in the Population Health Division, as well as some important opportunities we see in the field of sexual health. I'll start by reflecting on what we all know has been an extraordinarily tumultuous time with the COVID-19 pandemic and discuss the impact of COVID-19 on HIV and STI screening and prevention. The remainder of my talk will be about innovations and opportunities, because I think in many ways we are at a turning point in public health. We have vast amounts of work to do, and we also have many opportunities for improvements. I'll focus on our work in congenital syphilis prevention. I'll talk about some new programs we have to support home HIV and STI testing, and provide updates on where we are with biomedical HIV and STI prevention strategies. To begin, I'll provide a punchline, which is that HIV and STI cases in San Francisco declined in 2020. The total number of cases declined, and we'll review some of that epidemiology in detail. But first, I want to hear from you. What do you all think was the main driver of this decline? Do you think that this was primarily driven by a change in sexual behaviors, meaning people were having fewer sexual partners or less frequent sexual encounters, perhaps due to changes related to the pandemic? Or do you think the primary driver were declines in accessing services and participating in screening? Now, I realize many of you want to say both, but if you had to pick one, what would you say was the main driver? And you should see a poll pop up on your screen and be able to select. Okay, I'm going to advance and see if that allows me to see the results of the poll. Or there they are. Okay, so it looks like 3/4 of you feel like the main driver was decline in testing, and 1/4 think that there were likely significant changes in sexual practices and behaviors that may have driven a decline in incidence. And I'll go through some epidemiology here, and then you can reflect on if your thoughts on this have changed after I show you some data. So to frame the conversation, I think it's clear to all of us who work in healthcare and public health and in the safety net that communities with higher rates of HIV, hepatitis C, and STIs were also disproportionately impacted by the structural effects of the COVID-19 pandemic. Loss of income and jobs and people who are already living at the margins, intensified social isolation, increase in overdoses, loss of housing, lack of access to shelters. The effects were immense and profound. And when shelter in place went into effect, many in clinical and community-based services shut down or moved to a virtual platform. The public health workforce in huge numbers was redirected to fight COVID-19, including many of us in STI prevention, as our STI prevention disease intervention specialists and epidemiologists have formed some of the backbone of our COVID-19 response in San Francisco. There were dramatic declines in HIV antibody, HIV viral load, and STI testing. And we know those declines in testing have the potential to worsen existing disparities in rates of disease. This figure shows the number of HIV screening tests from select medical facilities from January 2020 through March 2021. The blue line represents the 2019 monthly average. And you can see there during shelter in place, which was highlighted in the red box, that we had a very steep decline in the number of HIV antibody tests conducted per month. And that starting in about June 2020, testing increased, but really didn't get back to pre-pandemic levels until March 2021. This figure shows similar data, but focused on our SFDPH public health lab, where much of our safety net, community-based HIV screening occurs, as well as STI screening. And again, you see the precipitous drop right after shelter in place, with some increases again starting in around June. But here you see that our gonorrhea and chlamydia screening numbers, represented in orange and green on this figure, have not gotten back to pre-pandemic levels as of about August 2021. We're getting there. We're at about 85%, but we still have a ways to go. So in terms of cases reported, this figure shows the number of HIV diagnoses, deaths, and prevalence in San Francisco from 2006 to 2020. And you can see that in 2020, we saw a continued decline in new HIV diagnoses from 168 in 2019 to 131 in 2020. This was a 22% decline, so a bit steeper than what we had seen in the preceding years. And we have been celebrating our getting to zero, HIV getting to zero efforts, and we want to see these continued declines. But we look at this number with caution, as we know that there were likely missed HIV diagnoses in 2020. And in fact, as of June 30th, 2021, we have had 78 new HIV diagnoses. So we're on track for somewhere around 160 diagnoses in 2021. It'll be the first year that we've had an increase from preceding years in quite some time. In terms of which populations are experiencing these declines in HIV testing or in HIV diagnoses, what you see here is that the changes are not the same across all populations, and that while overall HIV cases declined, they actually increased in cis women, heterosexuals, and people who inject drugs. And again, this is in the backdrop of an overall decline in testing, so quite concerning. Here you see incidents of gonorrhea, chlamydia, and early syphilis from 2016 to 2020. And just as we saw with HIV, we saw a decline from 2019 to 2020 in all three reportable bacterial STIs. And unlike with HIV, this decline is a new phenomenon. We have been seeing year upon year of increases in STIs. So this drop was really an anomaly and likely driven in huge parts by a decline in screening. The largest decline in STI incidence was for chlamydia in cis men. And as many of you probably know, chlamydia in cis men, particularly rectal chlamydia, is almost always asymptomatic. And so again, this is another reflection of the role of screening in driving this decline in cases. But what about sexual practices? I mean, they must have changed during the pandemic. We were sheltering in place. Their clubs weren't open, bars weren't open. People were, had a lot of concerns and fears about engaging in the world. And these data here show amongst our San Francisco City Clinic patients, the average number of sex partners reported in the prior 3 months. The green line represents gay bisexual men, the purple line represents women, and the orange line represents other men. And you can see that for gay and bisexual men, during those first 3 months of shelter in place, the average number of partners reported did decline quite steeply. And it rose over the course of 2020, but not back to pre-pandemic levels until around June 2021. So I think that the change in sexual practices did have a role in decline in cases, but probably secondary to the significant decline in screening. People ask, well, what happened with urethral gonorrhea? Urethral gonorrhea is a good indicator of true incidence because it is almost always symptomatic in cis men. And here you see by quarter the number of urethral gonorrhea cases in cis men from 2015 to 2021. And in fact, we do see a significant drop in urethral gonorrhea in those first months after shelter in place, reflecting likely some decline in incidence. And as of Q3 2021, we had 332 urethral gonorrhea cases, not quite back to the 374 we saw in the same quarter in 2019. The last couple of epi slides I will show are about female syphilis. And here you see that from 2019 to 2020, we saw an increase in syphilis in cis women. Again, this is despite everything else I've shown you, where for the most part, we saw declines in cases from 2019 to 2020. And this increase follows many years of sharply rising rates of syphilis in cis women. And in fact, we've had an 195% increase from 2017 to 2020. Lastly, this figure shows both the number of syphilis cases in cis women, as well as the number of congenital syphilis cases per year from 2014 to 2021. In 2020, we had 5 congenital syphilis cases. This is the highest number in several decades and is extremely concerning, as syphilis during pregnancy can be devastating. And these 5 cases, included 1 infant demise. So this is one of the top priorities of our program, is to prevent syphilis in pregnancy and to prevent congenital syphilis. Pregnant people experiencing syphilis experience many different vulnerabilities. Almost a third of our pregnant patients with syphilis were homeless, and very high proportions of cis women with syphilis, almost over 40%, report methamphetamine use. So in summary, HIV and STI testing declined significantly in 2020. And because most STIs and HIV are asymptomatic, we know that decline in testing means many misdiagnoses, which means missed opportunities for treatment, missed opportunities to prevent ongoing transmission. Overall, HIV diagnoses continue to decline, and cis women experienced a 29% increase in new HIV diagnoses and a 12% increase in syphilis diagnoses. There were no perinatal HIV transmissions, but there were 5 congenital syphilis cases, including 1 infant demise. I think that, as you've seen, testing capacity is increasing, but we do still have a ways to go, and we really encourage you to get your patients back in and get them back in routines of routine sexual health care. For the remainder of my talk, I will provide some updates on the work of our STI prevention program in the Population Health Division. Here you see a photo of some members of our incredible team. We were able to gather in June, pre-Delta surge, for a mostly socially distanced outdoor retreat. And I'm really grateful for all of the incredible people that work in this program. Our mission is to provide information, services, and policies that prevent STIs and HIV, promote sexual and reproductive health, and enable all people in San Francisco to have safe, healthy sexual lives. Our key focus areas of our program are testing and access, social determinants of health, collaboration and coordination, training and education, social media, messaging and technology, and data collection and utilization. As I've mentioned, our top priority is preventing congenital syphilis. The congenital syphilis epidemic is a phenomenon that is occurring across the United States. California is particularly hard hit. And the congenital syphilis epidemic is associated with high vulnerability, high rates of substance use, homelessness, and lack of prenatal care. The drivers of this epidemic are deep and structural and very challenging to address, and they require multi-sectoral collaboration and teamwork. To address congenital syphilis in San Francisco, we have a multidisciplinary cross-departmental task force whose work is guided by an A3, and I'm so grateful for Allison Decker and Liliana Osegueda from Maternal, Child, and Adolescent Health, who co-chair this task force, and for its many incredible and passionate members. Some of the activities the task force is working on are increasing syphilis screening in the emergency department, in urgent care, in jail health, and in street medicine. We're also working to improve referrals and coordination of services across the emergency department, homeless service providers, behavioral health, and pregnancy service providers. We're also working to increase providers' knowledge and comfort with sexual health care. One important update that we are working to disseminate to providers through many mechanisms, including this webinar today, are the 2020 CDPH expanded syphilis screening recommendations. These were updated and really give us a broader look at who we should be screening for syphilis. Some of the changes in these guidelines include screening all pregnant patients at least twice during pregnancy. So both once at the first prenatal visit, ideally in the first trimester, although of course that's not always when the first prenatal visit occurs, and again during the third trimester. In addition, the recommendations are that all pregnant people are screened at delivery unless they are low risk and have a documented negative screen in the third trimester. So this means syphilis testing 3 times during pregnancy for most people. All sexually active people who could become pregnant should receive at least 1 lifetime screening test for syphilis. This may be a change for you in how you think about who you screen for syphilis. We really are trying to take a broader approach. All sexually active people who could become pregnant should be screened for syphilis with each HIV test, really focusing on integration of services and paired HIV syphilis screening. And then in jurisdictions where congenital syphilis morbidity is high, and that includes San Francisco, emergency departments should be confirming syphilis status for pregnant people prior to discharge. Many of the pregnant people who have had syphilis in San Francisco are not engaged in prenatal care, and their only connection to services might be through urgent cares and emergency rooms. In addition, people who are or could become pregnant should be screened at intake into adult correctional facilities. The task force has led a lot of efforts to optimize the EPIC electronic health record that's used at SFDPH to facilitate syphilis screening and treatment. Some of these interventions is that we now have what I would call a flag in EPIC if someone has syphilis and has not been treated. You see it here in the orange box. Keep your eye out for that if you see it in a chart. And this is called an infection status column. It comes with some smart text and some tips about what to do, as well as how to reach us at City Clinic if you need help caring for the patient. We also, through our ER partners, have put in a best practice alert so that if a pregnant patient is in the ER and has not had a syphilis test in prior 3 months, a best practice alert pops up reminding the provider to order a syphilis test. A group of medical students has led a lot of work to increase syphilis screening in the SFGH ER, and we have seen results from their efforts. These figures here show the proportion of pregnant people who were tested in the SFGH ER or tested anywhere in our system in the last 2 months, both before their intervention and efforts, those are the dark blue bars, and then after their intervention, which are the turquoise bars. And you can see that they have made a difference with their work, which includes provider education, monthly recognition and gift cards, and visual cues throughout the ER reminding people to test for syphilis. Another way in which we're trying to increase access to HIV and STI screening is through the promotion of a home testing program. The program we've launched is called takemehome.org. This is in collaboration with the National Association of State and Territorial AIDS Directors, NASTAD, as well as a group called Building Healthy Online Communities, BHOC. This is a free program. We launched in February of 2021. Sorry. And individuals can order free HIV and STI tests and self-swab at home. They can do a finger stick to collect dried blood spots, and those dried blood spots are tested for syphilis and HIV antibodies in a lab. The population we're most trying to reach with this campaign are Black and Latino men who have sex with men, but anyone who resides in San Francisco and has not been tested in the last 3 months is eligible. So please do feel free to let your friends, your partners, your colleagues, and your patients know about this program. We're promoting it through a number of efforts, including a really incredible social marketing campaign led by my colleague Nicole Trainer in our Community Health Equity and Promotion Branch and 510 Media based in Oakland. The campaign is called Have Good Sex. It's a really, I think, visually incredible campaign built with a lot of input from the community. And we're promoting it through social media ads, through paid social media influencers who are popular and have lots of followers in the communities we're trying to reach, as well as through Comcast commercials and YouTube. Later this year, we plan to launch a second home testing program called Don't Think No. This program is geared for young women with a particular focus on young women of color. It's been around in other jurisdictions for some time, and through this program, women can order a kit and do a self-collected vaginal swab at home for gonorrhea and chlamydia screening. So once we launch, we'll be putting out more information, and again, hope that you'll be able to promote this program to your patients. In terms of highly effective sexual health prevention tools, we really can look no farther than PrEP. PrEP, as you know, has been an absolutely game-changing intervention and has changed the course of the HIV epidemic in the US and in the world. In 2019, the USPSTF gave PrEP its highest recommendation, a grade A recommendation, that we offer PrEP to persons at elevated risk for HIV acquisition. And just as we saw with HIV and STI screening, PrEP was also heavily impacted by the pandemic. Across the US and in California, there are data that the number of people retained in PrEP care, the number of people initiated on PrEP dropped quite significantly in 2020. And this is quite concerning for our ongoing HIV getting to zero efforts. Here you see the number of PrEP initiations by quarter at San Francisco City Clinic from 2017 through the second quarter of 2021. Very similar to all the other figures I've shown you with HIV STI testing, steep drop right after shelter in place with some rebound. Again, by the second quarter of 2021, we were at about 85% of our pre-pandemic quarterly PrEP enrollments. We've done a lot of work at the clinic to try to maintain access to PrEP and retain our patients in PrEP care, including during the pandemic, extending people's prescriptions and doing some telehealth. But again, we have a lot of work to do to get people back into PrEP care. And the good news is we're at an exciting time in PrEP. We now, as many of you may know, have two options for PrEP dosing. So in addition to daily PrEP, 211 or event-driven PrEP, intermittent PrEP is also an option. And this is a dosing strategy that's really ideal for people who can plan ahead for sex and maybe having sex a little less frequently, where one takes 2 tablets 2 to 24 hours before sex, and then an additional tablet 24 hours later, and a 4th tablet 24 hours after that. So a total of 4 pills to cover 1 sexual encounter. 211 has only been studied in MSM, although there are PK data that demonstrate that this dosing regimen is also an option for transgender women who are exposed through receptive anal sex. And we do offer 211 to MSM and trans women at San Francisco City Clinic. A couple of other cautions are that 211 should not be used in patients with chronic hepatitis B because the intermittent use of the medication can trigger a hepatitis B flare. It's a little less forgiving in terms of missed doses. And again, those first 2 doses do need to be taken at least 2 hours before a sexual encounter. While the CDC continues to recommend daily pre-exposure prophylaxis, it's the only licensed indication by the FDA. The IAS USA guidelines do recommend 211 as an alternative, as does SFDPH. And more good news, emtricitabine tenofovir, otherwise known as branded Truvada, is now generic, and PrEP services are required to be covered by insurance plans in California as of January 1st, 2021. So PrEP is becoming more and more affordable, and affordability really should not be a barrier to access to PrEP. The generic version of emtricitabine tenofovir costs about $30 for 30 pills. There is still a patient assistance program through the pharmaceutical maker that's available for uninsured patients, and so that covers branded Truvada. So if someone is unable to afford the generic, this is a good option. And we are considering some scenarios at SFDPH in which we could purchase and directly dispense generic emtricitabine tenofovir to patients who have access issues now that the price has really dropped so precipitously. We also have emtricitabine tenofovir alafenamide as an option for patients with renal insufficiency. So one of the challenges with Truvada or tenofovir disoproxil fumarate is that it cannot be used in patients whose creatinine clearance is less than 60. So fortunately, we now do have an option for those patients. But I think for the most part, Truvada or tenofovir disoproxil fumarate is the best option and should be the first choice for most patients who are initiating HIV PrEP. There's a lot of data coming out that Descovy is being prescribed for patients who do not have any contraindications to Truvada. So it's an interesting phenomenon to be watching. And then lastly, in the PrEP pipeline, we have long-acting injectable options coming soon. Long-acting injectable cabotegravir is expected to be approved by the FDA in January of 2022. And cabotegravir intramuscular every 8 weeks has been shown to be highly, highly effective at preventing HIV. There are 2 landmark studies whose results have come out in the last year, HPTN 083, which enrolled cisgender men and transgender women, as well as HPTN 084, which enrolled young cisgender women. In both of these populations, in randomized studies in which long-acting cabotegravir was compared to daily oral emtricitabine tenofovir, cabotegravir significantly reduced the risk of HIV. And again, this is in comparison to a strategy, oral PrEP, which is already highly efficacious. So this is going to be a really exciting time as we roll out this new option and see how it fits into the toolkit, who chooses it, how are we going to implement it in a way to get it to those who maybe haven't been using oral PrEP for a variety of reasons, or those who just really feel like this will be a more convenient strategy for them and one that will optimize their adherence. In terms of HIV PrEP, I'll just close with this comment that I think it's important that we really rethink how we assess whether people are eligible for PrEP. We know that uncertainty about which patients are appropriate for PrEP is a critical barrier to access. And we also know that individual behavioral factors often do not predict seroconversion. There's data that the high HIV incidence among Black men who have sex with men is not explained by higher risk behaviors. And we also know that the CDC criteria for trans people underestimate PrEP eligibility. So another approach is really to present PrEP as an option for sexually active people and just have an open-ended conversation. Discuss with the patient whether PrEP is a good fit for their lives. Focus on their needs and wants, as well as pleasure and positivity, and de-emphasize the role of the provider as the gatekeeper. I'll add that the data I showed you at the beginning of this talk, I think really highlights where our gaps are. And we've seen increases in HIV, in cis women, in people who inject drugs, in people experiencing homelessness. These same populations are heavily impacted by our syphilis epidemic. And I think we really need to think about how we're offering PrEP to those populations. I have one last question and just a few other slides before we wrap up. So this is another audience opinion question. So you have a 29-year-old HIV negative MSM who is on HIV PrEP. He presents to your clinic requesting doxycycline for STI prevention. He has had syphilis once and rectal chlamydia 3 times, and he heard that some of his friends were taking doxycycline to prevent STIs. Would you prescribe him doxycycline 100 milligrams daily to take with his HIV PrEP? Describe him doxycycline 200 milligrams for post-exposure prophylaxis to take after every sexual encounter? Counsel him that there are no consensus recommendations on doxy for STI prevention and you're just not comfortable yet, given those unknowns? Or would you refer him to the doxy PEP study at San Francisco City Clinic? Okay, can we see the results of the poll? Okay, I'm so glad to see that 3/4 of you would refer the patient to our study at City Clinic. I will share a few comments on that. And another 17% said, I'm just not comfortable doing this yet. But there were a few of you, 7%, who would go ahead and prescribe them doxycycline daily, and a smaller percentage, only 3 folks, who said they would do this as PEP. So the largest study to date on doxycycline for STI prevention did use a PEP strategy. This was a study that was embedded in the overall EPERGAY study of intermittent PrEP. Patients were prescribed doxycycline 200 milligrams to take as PEP. There were 232 people enrolled. They were followed every 2 months for 10 months, and the efficacy data was quite promising. A 47% reduction in the overall risk of STIs and a 73% reduction in syphilis. However, there remain a lot of questions and unknowns about the impact of this longer-term use of doxycycline on antimicrobial resistance among STIs and non-STI pathogens. We are enrolling at City Clinic as well as at Ward 86 and 2 sites in Seattle for a study called DoxyPEP. And we are enrolling MSM and trans women who've had an STD in the past year. So far, we're about 50% to our enrollment goal of 780 participants. And we're looking both at the incidence of STIs as well as some of these key questions around the impact on antimicrobial resistance in both STIs and non-STIs, as well as the impact on the gut microbiome. So you can look at our website for details about how to refer your patients or have your patients call or drop in if they're interested. So as I said, we have much work to do in the field of sexual health, and I think a lot of opportunities. And all of our work is going to be impacted by the politics and the culture that we live in. And I think the pandemic has made it, incredibly clear to all of us the role of politics in public health. In sexual health, we must ensure that we continue to have health coverage for all and access to services. There's many policy issues related to LGBTQ rights, which are critical in our work. We need criminal justice system reform, much stronger efforts to address income inequality, and we need to ensure that there are sustained investments in public health after the COVID-19 pandemic. I want to thank many folks who provided data or slides for this presentation. Here you also see one of our fabulous registration staff at City Clinic, who's really the backbone of our team here. This is Wendy Ho, so thanks to Wendy. All right, well, here we are just to remind you of our overall agenda for the morning. I will take a few minutes of questions, and then I will introduce our next speaker. So thanks everyone for your attention.
Thank you, Stephanie. I know I just learned a lot. A lot has happened over the last couple of years. And we do have some questions. One, just to follow up on the DoxyPEP study. A registrant is curious, are there any incentives for participation in the DoxyPEP study?
Yes, participants do get a small stipend for each study visit. It's not a significant amount. It's really just to compensate people for their time and parking or travel fees to the visit. But there is a small stipend for each visit.
Thank you. And then regarding
and of course, everything is free. The antibiotic and STI testing is all free.
Thank you. Regarding your slide reviewing average sex partners for San Francisco City Clinic, is that average here the mean or a median?
That's a good question. That is the mean, and those data are in our monthly STD report that we put out. So if you're interested in that and other data, you can go to the providers section of our website and our data and statistics page. And you can also sign up to receive the monthly report if you're interested.
Thank you. And does the average number of sex partners there, is that based on people who actually came into the clinic?
Yes, so that is based on people who came into the clinic. And I think that's a very astute question, because the people who came into the clinic during shelter in place and during the pandemic were different. We did prioritize patients with symptoms. We prioritized people who were needing to initiate PEP or PrEP. we did less asymptomatic screening. But given that eligibility criteria, we actually would have expected the people we were seeing to be on the higher risk spectrum. So I would, we have to interpret those data with those cautions.
Thank you. And then we have some questions regarding the self-testing that you referenced. Are the counties you listed the only counties currently offering these tests for women?
So I think the counties on the screenshot, you can go to Don't Think No and check out the website. I think I showed you Alameda, San Diego, and Los Angeles. I don't know if those are the only counties in California. They may be, but I know many counties are looking at launching home testing programs. So it is possible that there are now other counties offering it or that plan to soon. And the California Department of Public Health and the CDC have been really trying to support and encourage jurisdictions in launching these types of home testing programs.
Great. And does the home testing program for men who have sex with men include gonorrhea and chlamydia, or is it just syphilis and HIV testing?
Yes, thank you for that clarification. It does. So the kit includes the ability to do these dried blood spots where you put a little spot of blood on a card, and those are tested for HIV using a combination antigen antibody test in the lab. And then for syphilis, using an EIA or treponemal antibody test. So that's one downside, and that test is not very helpful in people who've had a history of syphilis because they need an RPR. You'll learn more about that later. As far as gonorrhea and chlamydia, yes, the kit includes the ability to do a self swab of the throat and the rectum, as well as provide a urine sample. So it's 3-site gonorrhea and chlamydia testing. And also, while that program is being promoted for MSM, cis women, trans people, any people of any gender can order a kit and use it.
Thank you. And so we have a couple of questions around PrEP. Someone wanted to clarify, is FTC, TDF, or Truvada still recommended for PrEP over FTC, TAF, or Descovy?
Well, I think that, I don't know if the CDC or FDA explicitly comment on that. Descovy or FTAF is FDA approved for HIV prevention in people who are at risk of HIV primarily through receptive anal sex. It has not been studied in people who have a vagina, so that's another limitation there. But I think in terms of what's best, we have to take into account both efficacy, safety, as well as cost. And so there's not a lot of strong arguments for using FTAF in somebody who for whom Truvada or emtricitabine tenofovir bisphosphate would work well. There are also some risks and safety issues with FTAF that we don't have with Truvada, in that it is associated with small amount of weight gain and lipid changes that we don't see with Truvada.
Thank you. A quick one here, is PrEP covered by Healthy San Francisco?
Yes, I believe so. I mean, it is required to be covered by all, well, Healthy San Francisco is not actually a health insurance plan, but if you're on Healthy San Francisco and you need PrEP, you can get it for free, either through a patient assistance program or through other mechanisms. There may be some additional navigation required, and our amazing PrEP navigation team at City Clinic could answer that question for you if you'd like to give them a call and consult. Or if the patient is having challenges, they are also welcome to call for support.
Great. And then the last question is, what does it mean to be the STD controller of San Francisco? Can you explain what this role is?
Well, all counties are required to have an STD controller. STDs are required by the California Code of Regulations to be reported by both labs and providers. And so really, actually, STD prevention was one of the first things that occurred in public health. And so the controller is really responsible for overseeing a program that does a surveillance of STIs, as well as programmatically that supports efforts to prevent and control STIs.
Thank you. I think we are at 9:50 now.
Okay, well, thanks for everyone's attention and for those great questions. I am now just thrilled to introduce our next speaker, Dr. Kelly Johnson. Dr. Johnson is a public health medical officer in the STD control branch at the California Department of Public Health and is an assistant professor of medicine in the Division of Infectious Diseases at the University of California, San Francisco, as well as a clinical faculty member with the California Prevention Training Center. Dr. Johnson is board certified in internal medicine and infectious diseases and works as an HIV care provider at Zuckerberg San Francisco General Hospital. Her research interests include the intersection between HIV and bacterial STIs, as well as real-world implementation of HIV PrEP. I've had the pleasure of knowing and working with Dr. Johnson since her days as an internal medicine resident. She's an incredible teacher and speaker, and you are going to learn a ton from her about syphilis in this next talk. So thanks so much, Dr. Johnson, for participating in our webinar today. Let me stop my screen share and turn it over to you.
Thank you so much, Dr. Cohen, for that wonderful introduction, and especially to all of you for being here. I'm going to take just a second to go ahead and share my slides. Okay, so this will be an introduction to syphilis. And again, I am so excited to be here and to share this information with you all. In terms of our objectives for today, this will just be an STI update, and we're going to use a case-based approach. So with that in mind, I will jump right into the case. So this is a 35-year-old bisexual male presenting to clinic with genital ulcers. The ulcers are a little bit painful, but they're not pruritic. There are several of them. The patient's physical exam reveals the following findings. So as you can see in this image, this is a shaft of a penis. There are multiple erythematous, shallow-based ulcers. I'll give you a second to look at it, and then let's go ahead and open the first poll question. So I'd like you all to think about what is the most likely diagnosis. Is it genital herpes? Is it primary syphilis? Is it secondary syphilis? Is it chancroid? Or is it pityriasis rosea? Okay, please go ahead and share the results of the poll. Okay, so most of you, 46%, did get that this is primary syphilis. That is the correct answer here. And of course, this is a talk about syphilis, so maybe not super surprising, but that said, it's still about half of us picked other diagnoses. And that sort of underscores the fact that syphilis can look like a lot of different things. And historically, people may have actually thought that this is herpes due to the fact that there are multiple lesions and they're somewhat painful. But in fact, again, this is primary syphilis. Now, we might tend to think of primary syphilis as a single ulcer with raised borders, but we're seeing more and more cases that look like this, with multiple lesions and a somewhat atypical appearance. So just to take a step back and think about an overview of syphilis. So syphilis, as you all may know, is caused by a bacterium. It's a spirochete called Treponema pallidum. It's transmitted primarily by direct contact to infectious lesions, but can also rarely be bloodborne, like in the case of transfusions, and of course can also be mother to child, as we'll discuss. The incubation period on average is about 3 to 4 weeks, but the range can be quite long, and in fact up to 90 days, which I think is interesting about syphilis. And syphilis causes systemic infection with episodes of active disease or symptomatic disease that are interrupted by periods of latent or asymptomatic infection. You're going to see this slide a lot, but this is the natural history of syphilis. As I mentioned, this infection is characterized by these episodes and stages of active disease, during which time patients have signs and symptoms of their infection, but that's interrupted by periods of latent or asymptomatic infection. Serious complications, including CNS infection, which is neurosyphilis, as well as congenital syphilis, which Dr. Cohen mentioned, and that's maternal to child transmission, they can occur at any stage of the disease. And I really want that to be a main takeaway that you get from my talk today. Now we're going to start on the left-hand side of this slide, and this is where we find our patient by discussing primary syphilis. So after exposure, again, there's that incubation period, 3 to 4 weeks, then a syphilitic ulcer or chancre appears. This initial lesion is a papule. It appears at the site of inoculation or exposure, and then it grows and ulcerates, ultimately producing the typical chancre of primary syphilis. Now again, classically, this ulcer is single, painless, indurated, there's minimal exudate, and it can have these raised edges that are a bit rubbery in nature. The patients can also have regional painless lymphadenopathy on exam, and that's important to know because if a patient has that, you might start thinking about other diagnoses like LGV, but that can also happen with syphilis. Now, importantly, and as I mentioned, since primary syphilis ulcers are often painless, they can go unrecognized, and that's especially true if they're in places like the vagina or the cervix or the anus or the rectum, where patients might not even know they're there. Also, sometimes syphilis lesions can be a bit painful, like what we're seeing in our patient, and there can be multiple lesions. So these types of lesions can often be confused with herpes or with other diagnoses when patients have several chancres. And this was the first misstep in the case we're discussing. Now we'll take a look at some images of primary syphilis. Again, classically single, painless, indurated, clean-based lesion with rolled, rubbery, raised edges, rubbery border, can go unrecognized. But again, syphilis is sort of called the great masquerader for a reason, and the manifestations of even primary syphilis are often not textbook. I really want to direct your attention to the middle photo on this slide. This is a patient with a vagina, and it's one example of atypical syphilis presentation. Now, people with HIV are somewhat more likely to have this kind of presentation with these multiple ulcers. One teaching point or learning point for this slide is that herpes lesions can sometimes be called kissing lesions, where a herpetic lesion auto-inoculates an opposing mucosal surface, kind of like a textbook closing. And that's not seen on this slide, actually, and that could be an early tip-off that, in fact, this is not herpes, and instead it is syphilis. A little more primary syphilis, just so you can burn these images into your thinking. These are primarily lesions of primary syphilis. And again, especially if you look at that top middle photo, you can see how this photo of anal lesions could easily be mistaken for the kissing lesions of something like herpes. Now remember that the chancres of primary syphilis appear at sites of inoculation or exposure, wherever they might be. So this can include extragenital anatomic sites, as shown here on this patient's tongue, fingers, and lips. And we'll go back to our patient. So after examining the patient's genital ulcers, the provider suspects genital herpes, and we've kind of talked about why that might be the case. So the patient's prescribed acyclovir to treat his herpes, and his ulcers resolve entirely. He feels well. He returns a few weeks later, this time with a diffuse but subtle non-pruritic rash. And I'll show you what the rash looks like on the next slide. So this is a diffuse, subtle maculopapular rash. You might be thinking it looks a bit like a drug rash, in fact, if you've seen those before. And I will take a second to have you please open the next poll question. So what is the most likely diagnosis now? Is this secondary syphilis? Is it tinea versicolor? Is it Coxsackie virus or hand, foot, and mouth disease? Is it atopic dermatitis, or is it contact dermatitis? Great, okay, please show the poll results. Wonderful. So 99% of us guessed secondary syphilis. And at this point, you're on to me, and that is the correct answer. And the reason, I'm talking about syphilis, and the reason I'm showing this list is, again, not so much to confuse you for this talk, but rather to show you that in the real world, if you weren't thinking about syphilis, it would be easy to think about instead some of these alternative diagnoses. So just keep that in mind when you're seeing your patients. So now back to our natural history slide. One point I really also want you to take home is that the chancre that we saw of primary syphilis can actually resolve on its own, even if the patient never gets any treatment. It may also overlap with the next stage of infection, secondary syphilis, which of course is where we now find our patient. Now with secondary syphilis, rash is the most common manifestation. As you may know, this rash classically and often involves the palms and soles. But secondary syphilis can also present with a number of other manifestations, things like generalized lymphadenopathy, constitutional symptoms like low-grade fever, malaise, sore throat, headache, things that can really be nonspecific. It might seem a bit like flu or a nonspecific viral illness and might not necessarily make you think right away of syphilis. Patients with secondary syphilis can also present with these oral lesions called mucus patches, which we'll discuss, or condyloma lata, which can look a bit like anogenital warts, and we'll take a look at those as well in a few minutes. Patients with secondary syphilis can also have patchy alopecia, and in fact, that can even occur just around the eyebrows. They could also have a subclinical hepatitis, and that might just be detected on lab tests showing abnormal LFTs, especially an elevated alkaline phosphatase could be a tip-off. And again, like we saw with primary syphilis, these symptoms of secondary syphilis also typically resolve on their own over time, even if the patient never gets any treatment. Interestingly, in about 25% of patients, there can later be a relapse of secondary syphilis symptoms, which is just another interesting fact and something to know. So we'll take a look now at the rash of secondary syphilis. So again, classically it's diffuse, it's a maculopapular rash, it involves the palms and soles, but this rash again is often missed by providers who don't identify it because it's subtle and because it can have an atypical appearance. I'd especially direct your attention to the middle photo on this slide and just notice that this might not be what you classically think of, these sort of red coin-like lesions, a bit scaled perhaps. You might not jump syphilis right to the top of your differential. So the main point is that even if the rash is very subtle or atypical, remember that it's important to think about syphilis and to look at the hands and feet, because that can be a tip-off. Even if you're looking at the hands and feet though, I do want to direct your attention to this photo on the left-hand side of this slide, because you can see that these palmar and sole lesions here, they almost look like scars. They're old, they're hyperpigmented. Again, this could be another reason where a diagnosis of syphilis is missed. More images of secondary syphilis. These are mucus patches, which are these white plaques that appear in the mouth. These are highly infectious, and they could also be confused with other things that cause white plaques in the mouth, which we'll take a look at. So things that might be otherwise on your differential diagnosis include thrush, which is on the left-hand side of this slide, or oral hairy leukoplakia, which is on the right-hand slide. Now with thrush, this is classically more diffuse. It can usually be scraped off. It's often a bit more white in appearance as compared to what you see on this slide, but hopefully you get the general sense of what thrush looks like. The image on the right is the oral hairy leukoplakia. And this is typically a white lesion that has actually vertical lines within it. That's not super well seen on this slide, but what is seen really well is that it's often located on the lateral border of the tongue, such that the patient may have to stick out their tongue and direct it over to one side in order for you to see the lesions. Another image of syphilis, secondary syphilis, this is patchy alopecia. And of course, this just looks like alopecia. It could be easily confused with alopecia areata or sort of regular alopecia. Again, just another place where a syphilis diagnosis could be missed. Now here are these condyloma lata, which I started to discuss. This is a term for large, raised, whitish or gray lesions. They're usually found in moist areas like the perineum, the perivulvar area, or around the anus. And like mucus patches, these lesions are also highly infectious. And you can see how these might be confused for anogenital warts. So whenever you see what you think are anogenital warts or condyloma acuminata, you should also be thinking of condyloma lata and secondary syphilis. Just to burn that into your thinking a little bit more, this slide is meant to compare and contrast condyloma lata, syphilis, with condyloma acuminata, warts. So whereas the condyloma lata that we just saw on the last slide are flat on top, the condyloma acuminata or anogenital warts here on this slide have a more cauliflower-like or irregular appearance, as you can see. So let's get back to our case. After evaluating the patient's rash, the provider suspects contact or allergic dermatitis, prescribes a topical steroid. The patient uses the steroid, his rash resolves, he feels totally well. He comes back for a routine physical exam and checkup a few months later. He has no acute concerns at that time. A sexual history is not taken, and he's not screened for sexually transmitted infections. So let's look at our natural history slide again. Our patient is now in a latent phase of disease, which, as we discussed, is an asymptomatic phase of disease. Now, early latent syphilis is when the only evidence of disease is laboratory evidence and/or a clinical history that a syphilis infection likely occurred within the past 12 months. Otherwise, if you're beyond that 12-month mark, the diagnosis would be considered late latent syphilis or syphilis of unknown duration. And that distinction really does matter because the treatments for early and late disease are different, and we'll discuss that a little bit later in the talk. So back to our patient. 2 years after resolution of his rash, he comes back to clinic. He has slight hearing loss and new mild headaches. The provider tests the patient's hearing in office. He doesn't find any obvious deficits. He does not choose to pursue any further testing. The patient's reassured, nothing to worry about, go on home. He's told to come back to clinic if his symptoms get worse from here. So I won't make this as an audience question because I think that you're on to me by now, but just to think about if you saw this patient in clinic, some things that might be on your differential for hearing loss and headaches in a young patient. You might be thinking about cholesteatoma, otitis media, neurosyphilis, or age-related sensorineural hearing loss. And of course, this is neurosyphilis. And what I want to mention with this patient's presentation and for you all to know is that one of the first and earliest subtle findings of neurosyphilis can be hearing loss. So do take that seriously and do think about syphilis if you have patients who could have been exposed who are coming in with these types of symptoms. So again, the whole point of this slide is to drive home the point that neurosyphilis, as well as ocular syphilis, can occur at any stage of syphilis. It is a common misperception that these manifestations can only occur in late syphilis, and that is not true. So I hope you will take that away from this talk. So let's take a moment to briefly discuss neurosyphilis. Our patient's symptoms at this point are potential manifestations of early neurosyphilis, which occurs months to years after the initial infection. These early manifestations can include things like cranial nerve dysfunction, meningitis, stroke, altered mental status, or hearing or vision changes. Early manifestations can also include otosyphilis, which is a syphilitic infection of the cochleovestibular system. That can present with hearing loss with or without tinnitus. Ocular syphilis is another potential early manifestation of syphilis, and that has a variety of potential manifestations. Now, late manifestations of syphilis, neurosyphilis rather, occur 10 to 30 years after infection. And these can be pretty significant neurologic deficits, things like tabes dorsalis and general paresis. And this can basically present with things as severe as dementia, incontinence, serious gait abnormalities. So remember that syphilis, and especially neurosyphilis, can also present that way. I also just want to mention that if a patient has untreated HIV or AIDS, neuro and ocular syphilis timelines are shortened considerably. But the bottom line is that all patients with syphilis diagnosed at any stage should be assessed for neurologic signs and symptoms. You want to do a full neuro exam, including assessment of cranial nerves and any ophthalmologic or auditory symptoms. And then if there's clinical evidence of neurologic involvement, like if you see a cranial nerve deficit on exam, you want to have a low threshold to perform an LP to diagnose neurosyphilis. So let's go back to our case. So our patient presents to the ED a few days after his last clinic visit. And at this point, his headaches have worsened to the point of becoming quite severe. The ED physician now does a CT brain, an LP. A cerebrospinal fluid VDRL is sent as part of the routine workup for meningitis. The VDRL results positive, and of course the patient is diagnosed with neurosyphilis. He's admitted for treatment with IV penicillin. Meanwhile, a few months after our patient's last clinic visit, one of our patient's female partners delivers an infant at 38 weeks pregnant. The mother received no prenatal care. The newborn appears ill with copious nasal discharge, hepatosplenomegaly, lymphadenopathy, a rash, and jaundice. And their CSF analysis also reveals a positive VDRL, confirming an unfortunate diagnosis of congenital syphilis, which I know Dr. Cohen has already spoken about a bit this morning. And what I really want to emphasize is that this unfortunate case of congenital syphilis could have been avoided entirely if our original patient had been tested for syphilis so that his sexual partners could also be tested and treated, as well as if this mother had received syphilis screening through any prenatal care. So just another reason to remember those expanded syphilis screening guidelines and to be thinking about syphilis if you are seeing pregnant patients in your practice. So a little bit more on congenital syphilis. What is it and why is it of the utmost importance? Well, congenital syphilis, again, is syphilis infection of a baby transmitted in utero from its mother, and it can be fatal. In fact, some CDC estimates suggest that up to 40% of babies who are born to women with untreated syphilis may actually be stillborn or die from their infection. That said, many infants with CS or congenital syphilis are asymptomatic at birth. However, early manifestations of CS occurring shortly after birth and actually up to 2 years can include the things you see on this slide. So that includes hepatosplenomegaly, enlarged liver and spleen, snuffles, which the infant in our case also had, and they're these copious nasal secretions that you see in this image here. Babies may also have mucocutaneous lesions. They can have this thing called pneumonia alba, which is like a white pneumonia, and it's a collection of inflammatory cells, fibrosis, and spirochetes within the alveolar septa. It can look like a pneumonia on chest x-ray. And then there are a number of bony abnormalities that can be classic for early syphilis. That can include things like osteochondritis or what's called pseudoparalysis, essentially where a baby looks partially paralyzed, they're not moving a limb, and that is because of the bony abnormalities and potentially fractures that have occurred as a result of their syphilis infection. Babies with congenital syphilis, of course, can also have edema. They can have a rash like our baby in this case did. They can have lymphadenopathy, and they can also have lab abnormalities like hemolytic anemia or thrombocytopenia. Congenital syphilis can also have physical findings that occur later, potentially up to 2 years of age for the baby. And these findings include the things that you see on this slide. So there can be interstitial keratitis, which is a problem with the cornea. There can be eighth cranial nerve deafness. There can be teeth abnormalities, these Hutchinson's teeth, which you see in this middle top photo here. Again, they can have abnormal molars, these things called mulberry molars. And they can also have bony abnormalities. They can have an abnormal forehead appearance, something called frontal bossing. They can have a saddle nose, or they can have these Clutton joints, which are symmetric, painless swelling of the knees. They may also have perioral fissures. Of course, as I mentioned, and is really the most important part of this section of the talk, congenital syphilis can also be fatal. And it's really important just to emphasize the fact that CS deaths are largely preventable if mothers are successfully diagnosed and treated either before they ever become pregnant or earlier in pregnancy. In fact, as shown on this slide, mathematical modeling studies have estimated that about 70% of CS stillbirths are likely avoidable if syphilis treatment is given by 21 weeks of gestation. Now, obviously, in our case, this was not possible. It was quite unfortunate. And that's because, again, neither our original patient nor his female partner were ever screened or treated for syphilis. And that has the consequence that they were never able to receive proper treatment. Now, we'll review the natural history of syphilis one more time. Again, emphasizing the fact that maternal fetal transmission can occur at any stage, and also that CS is preventable. So at this point, we've reviewed primary, secondary, and latent syphilis, as well as congenital syphilis, and we've touched on neurosyphilis. Now, just to conclude the natural history, note that tertiary syphilis is another potential very late manifestation of syphilis, which we don't see super often in the modern era of antibiotics. But just so you've heard it somewhere, tertiary manifestations can include things like gummas, which are these proliferative, granulomatous, inflammatory lesions that may be destructive of organs, including things like the skin, the liver, the bone, or even the brain. Tertiary manifestations can also include cardiovascular manifestations, things like aortitis or aortic aneurysms. And of course, there can also be CNS abnormalities, like we discussed before, things like tabes dorsalis and general paresis. So now we're going to move into a section of the talk on syphilis diagnosis. Now that you've learned how to recognize syphilis in all of its different stages, let's talk about how to diagnose it. And I will start with an audience question here, and if you could open the final poll question, please. So in this slide, we're going to talk about how to diagnose syphilis, and I'll clarify that this should be initial diagnosis of syphilis. So I'd like to know what you think are tests or a test that it is or are needed to diagnose syphilis. Is it a treponemal test, like a TPPA, an EIA, or a CIA, things that detect antibodies to syphilis? Is it a non-treponemal test, like an RPR or a VDRL? Or is it both, a non-treponemal test and at least one treponemal one? Great, please show the poll results. Great, okay, so we do have people choosing all three choices here, but the majority, 74%, think that the answer is C, both a non-treponemal and a treponemal test. And wonderful job, that is the correct answer. But I do want to take some time to talk about syphilis diagnosis because it can be a confusing topic and because there are different screening algorithms that you should be aware of. So one thing to know is that direct detection of T. pallidum, the organism of syphilis, from clinical specimens can really only be done by things like dark field microscopy or PCR, and unfortunately neither of these things are widely available. So for that reason, syphilis diagnosis relies heavily on serologic testing, with tests that fall into the two categories that you see on this slide. Again, you need both types of serologic tests to confirm a new diagnosis of syphilis. So on the left-hand side, you see our non-treponemal tests. These are things like the RPR and the VDRL. These are quantitative tests allowing for assessment of disease burden, treatment adequacy, and reinfection. But the thing about them is they're nonspecific, and they can be positive in patients with other conditions, things like lupus or autoimmune diseases or even pregnancy. So you also want to do treponemal testing, and that's things like a TPPA, an FTA antibody, an EIA, or a CIA. These tests detect antibodies that are specific to T. pallidum. But these antibodies usually stay positive for life after an initial infection. And they're not quantitative, so they can't be used to assess for reinfection, and they can't be used to assess for response to treatment. Now, there are two different ways that you can screen for syphilis. One is via the traditional screening algorithm, and the other is the reverse screening algorithm, and that's being used more frequently. We'll go through each of these in turn. But I just want to say off the bat that it can be quite helpful to know which screening algorithm your lab is using, because that might help you best understand how to interpret the results that you're seeing. So we'll start with the traditional screening algorithm. This one in some ways is a bit less complicated. So for the traditional screening algorithm, you start with an RPR. If the RPR is negative, that's it, you're done, testing stops. But if the RPR is positive, the test should reflex, as you see here, to a treponemal test, such as a TPPA. If the TPPA is negative, syphilis is unlikely, and the positive RPR that you saw is probably a false positive. On the other hand, if that TPPA is positive, this indicates that your patient has either past or present syphilis. The patient's clinical and testing history can then be used to determine whether this is an old treated infection, a past infection that has potentially not been treated or been inadequately treated, or if this is a new infection. And pertinent information that you need to make these determinations includes things like any symptoms of primary or secondary syphilis, any prior known syphilis diagnosis or treatment history, and RPR or VDRL titers, with a fourfold change from prior being considered clinically significant. And we'll talk about that a bit more. But for now, let's move on to the reverse screening algorithm. So in the reverse screening algorithm, you start with a treponemal test, like an EIA or a CIA, something that detects antibodies. If that's negative, in this algorithm, you're done, testing stops. But if it's positive, a standard RPR is performed next. If the RPR is reactive, the patient again has past or present syphilis, just like we saw with the traditional screening algorithm. You can then use the clinical history and any prior available RPR titers to determine the likelihood of a new versus old syphilis infection, as well as the stage of syphilis. But if the RPR is negative, things get a little bit more complicated. A second treponemal test, which is usually a TPPA, is done next, sort of as a tiebreaker. If the TPPA is negative, syphilis is generally unlikely. But if the TPPA is positive, here you have confirmed past or present syphilis. And management at that point, again, depends on the clinical scenario. So, for example, if the patient has a known history of treated syphilis and they don't report any new exposures, then the positive EIA or CIA and the positive TPPA that you saw, those likely represent prior exposure and no further treatment is needed. Otherwise, patients who don't have a known history of treated syphilis, but do have a positive EIA and a positive TPPA should be offered treatment for syphilis. Unless the patient's history or the results of your physical exam suggest a recent infection, something that occurred within the past 12 months, then previously untreated persons who have this finding should be offered treatment for latent or syphilis of unknown duration. Now, I know that was a lot of information and that syphilis serology interpretation can be a complicated topic. I didn't go into all the nuances of different ways to interpret different combinations of syphilis titers, but I want to direct your attention to this resource that was recently developed by the California Prevention Training Center. It is a PDF that essentially presents both screening algorithms and then has a table underneath explaining how you might interpret different combinations of syphilis serologies that you're seeing. I know that you can't read this on this slide. I just want to make sure that you know this resource is available, and I hope that it's helpful for you in the future. So the last thing I'll say about syphilis diagnosis, the main thing to know with non-treponemal titers is how do you interpret them? The bottom line is that a fourfold change in non-treponemal titers like an RPR or a VDRL is considered significant. A fourfold decline can indicate adequate response to treatment, whereas a fourfold increase, on the other hand, is suggestive of a new infection, especially if sustained over 2 weeks. A last point I'll make is that you want to compare titers using the same serologic test. Like if you sent an RPR before, send an RPR again, just to make things less confusing for yourself, because in general, RPRs tend to be higher than VDRLs, and you want to be able to compare like-to-like test. So the last section we'll move into is syphilis treatment. I've alluded to this a bit, but appropriate treatment for syphilis depends on the stage of syphilis. You're going to see that in the following slides. So for early syphilis, so primary, secondary, and early latent syphilis, the treatment of choice is benzathine penicillin G. It's dosed at 2.4 million units, it's given IM, and it's given in a single dose. Bicillin LA is the trade name for this particular medication. We've seen errors where people are using bicillin CR, and so I just want to say explicitly that bicillin CR, it's a combination of short and long-acting penicillins, and it's actually not considered an effective treatment for early syphilis. Now, there are alternatives to penicillin for non-pregnant penicillin allergic adults. That could be doxycycline for 2 weeks, tetracycline for 2 weeks, or ceftriaxone for 10 to 14 days. I've made them really small on this slide because I really want to drive home the point that you really want to be using penicillin if at all possible. It is the preferred treatment for syphilis. So moving on, I mentioned this before, but syphilis of late or unknown duration is treated differently from early syphilis. It is treated the same medication, so still bicillin or benzathine penicillin G, but your dose is now given as weekly doses times 3. And the maximum interval between these 3 doses can be 10 to 14 days in non-pregnant patients, but pharmacologic considerations suggest that 7 to 9 days is really more ideal. And very importantly, a 7-day interval is optimal in pregnancy. Why is that? That's because 40% of pregnant women are actually below treponemocidal levels after just 9 days. And another thing really important to not forget is that if a dose is missed or not given at the proper intervals, you actually have to restart the entire series of 3 weekly doses in order to appropriately treat your patient. And again, there are alternatives here, doxycycline and tetracycline for a longer period of time for 4 weeks, but I would really highlight that that is harder to be adherent to and much less preferred. In addition, syphilis in pregnancy. Penicillin is the only treatment for syphilis in pregnancy. You want to treat a pregnant patient with the penicillin regimen that's appropriate for their stage of syphilis infection. And just so you've heard it somewhere, I'll tell you that some experts do recommend a second dose of bicillin given 7 days after the first dose for early syphilis in pregnant people. So you might see that. Really can't emphasize enough that pregnant people who have a history of a penicillin allergy should be desensitized and still treated with penicillin. Also, of course, all patients with syphilis, and especially those who are pregnant, should also be tested or screened for HIV, as we know that co-infections can occur. Finally, neuro and ocular syphilis, which we've just touched on briefly, but I just want to show you that they're also treated differently. Neuro and ocular syphilis are treated with IV penicillin, which is aqueous crystalline penicillin G. It's given every 4 hours or via continuous infusion for 10 to 14 days. And again, there are some alternative regimens, but you should really only be using this if compliance with therapy is impossible on the IV side. One thing again that I'd like to know when we're talking about treatment, or I'd like you to know rather, is just the importance of performing a day of treatment titer. The day of treatment titer establishes a baseline by which to compare response after treatment. This is a frequently forgotten component of syphilis management, and without a true baseline documented, it can make assessment of titer response quite difficult. And you can kind of see this on this slide. So a patient presents, they're diagnosed with syphilis, they have an RPR over here, it's 1 to 256. They're not treated on the same day. They come back for treatment, but on the day they come back for treatment, an RPR is not rechecked. And it turns out it was actually quite a bit higher. In fact, it's now 1 to more than 1,000. And so then the patient comes back, say 3 months later for their syphilis monitoring, and they have an RPR, and it's 1 to 256. If you did not know about this quite high titer on the day of treatment, you really wouldn't be able to interpret this 1 to 256 response, and you might be worried that perhaps the patient has been re-exposed or didn't respond to treatment appropriately. So just to save yourself that confusion, really emphasize getting that day of treatment titer, if at all possible. So I'll give some conclusions for my talk, things that I'm hoping you can take away from what we've discussed. So as we saw with our patients, syphilis presents differently in different stages of disease, and it's really easy to misdiagnose. It can present a lot of different ways. Now, left untreated, patients progress through stages of active disease interspersed by these periods of latent disease. And many things like the chancre of primary syphilis or the rash of secondary syphilis, they go away on their own, even if the patient doesn't get any treatment. Now, as we saw in our case, the outcomes of untreated primary, secondary, and latent syphilis can be as severe as congenital syphilis, neurosyphilis, and ocular syphilis. Neurosyphilis and maternal fetal syphilis, or CS, congenital syphilis, can occur at any stage of disease, really important to remember. As we just discussed, the diagnosis of syphilis involves both treponemal and non-treponemal tests. Syphilis is treated differently depending on the stage of disease, but really want to highlight penicillin as the drug of choice. And finally, the main takeaway, remember to include syphilis on your differential diagnoses and to screen broadly to avoid some of those complications that we saw with our case. Final slide, just want to remind you, as Dr. Cohen talked about PrEP, here are the CDC indications for HIV PrEP. CDC states that HIV PrEP should be offered to sexually active individuals with syphilis or any other bacterial STI that have been diagnosed or reported in the past 6 months. So if you're seeing a patient with syphilis, remember to think about PrEP and to offer it to your patients. I'll thank you for your time now, and I think we do have about 9 or 10 minutes for questions.
Thank you, Kelly. Very intriguing, covered a lot of material. Thank you for fitting that all in that short amount of time. I know that was a lot of information, but we also have a lot of questions. So hopefully we have some time to get to some of these.
Okay.
Okay, so regarding some diagnostic questions, is dark field currently recommended for lesions suspicious of primary syphilis?
So dark field is sort of the gold standard to diagnose syphilis. So if you have access to a dark field microscope, that's great. I know San Francisco City Clinic, for example, does have a dark field microscope. And so they are performing dark field microscopy if they see a lesion that they think could be consistent with primary syphilis. But for most places, That's not an option. We don't have access to dark field microscopes, including, for example, like where my clinic is and the main academic hospital where I practice. To my knowledge, there's not a dark field microscope in those locations. So for that reason, for most of you, you're likely to have to resort to the serologic testing for your syphilis diagnoses.
Thanks, Kelly. So a question here is the EIA syphilis test preferred rather than the FTA ABS? And what are the specificity, sensitivity of the treponemal and non-treponemal test available?
Yeah, there's actually, for the sensitivity and specificity, there's actually a really great paper that was written by Dr. Ina Park, who you're going to hear about later. And I think to answer that question, perhaps if possible, we could send that paper out with the resources that we include after this talk for the audience. I think that's probably the most comprehensive way to share that data. As to the comparison between EIA or CIA and FTA antibodies, I don't know the numbers directly off the top of my head. But in all cases where I've seen labs using the reverse screening algorithm, I can tell you they are typically starting with that EIA or CIA.
Great. And here we have a question from someone who uses the Syphilis Health Check rapid syphilis test in their clinic. And they want to know, they're saying the lab I use does not do a TPPA if the RPR is negative. Is this something I need to request if the client has a positive EIA in clinic, meaning a rapid positive syphilis health check test?
I see. So let me make sure I understand the question right. So you're saying that at like a point of care test, you have an EIA that's positive?
I believe that's what she's saying, that the syphilis health check is an EIA test. So I think that's what she's saying.
Mm-hmm. Thank you for that clarification. And at the same time, like an RPR sent to your lab is negative?
Yes.
Yeah, I mean, I think to really interpret that correctly, if you want to go down the reverse screening algorithm, it would be necessary to get that next treponemal test done. So I would suggest doing that. I would say there are cases where the EIA or CIA actually becomes positive first after a syphilis exposure. So if you're really worried about syphilis, either from the history or from something you see on physical exam, then I think it's totally appropriate to still go ahead and treat your patient just based on what you have with your rapid syphilis check.
Yep. And I think I have some experience with this test. And so with an EIA, it could be a false positive or with an RPR being negative, but it could also be someone who has like latent untreated syphilis so that their RPR is negative. But if you did a TPPA, it would be positive. So I do think you would need that test to differentiate a false positive versus someone who's either been previously treated or has latent syphilis, or like Kelly said, very early syphilis.
Yeah, totally agree with that. I think everything you said, completely agree.
Okay, and I know, Kelly, that you don't technically work for the Department of Public Health, but you have experience. You mentioned that second benzathine shot for pregnant people with early syphilis. Do you know what the SFDPH's position is on that? And
Oh my gosh, that's such a good question, but you're totally right. I don't know the answer. Allison, do you know the answer? Because I'm not directly working at City Clinic anymore.
I'm not seeing this in practice, and I don't think this is currently our recommendation. That we're just going with one dose of benzathine penicillin for pregnant people if they have.
Hi, this is Oliver. I can chime in if you'd like.
Oh, wonderful! Yeah.
Yeah. So, hi Ken. Thanks for that excellent question. The CDC is quite coy in its guidelines about this. Some experts recommend it, others don't. The data for this is based on a couple of very small studies. And it is not generally part of standard recommendations. Some people do it. I don't think there's any harm in doing it, but there's certainly not randomized controlled trial level evidence indicating an improved outcome.
Thanks, Oliver. So it sounds like, if you have a pregnant patient with early syphilis and they get that one dose of bicillin, you can consider them adequately treated, but just know that some experts might treat with a second dose 7 days later.
I would agree with that.
Thank you.
Thank you.
So I see we're running out of time. I am just going to ask one question. And And this is regarding the different intervals for treatment for latent syphilis in pregnancy. Kelly, would you be able to address the differences like with what the CDC is saying versus the state? And maybe
Yeah, I can. And I think it's a really important point. So I'll preface it just by saying there is not a lot of great data about what the maximal allowable interval in pregnancy is. We do know, like I said, that after 9 days, about 40% of pregnant people will have drug levels that are below treponemicidal levels. So you don't want that. The CDC, in their 2021 STI Treatment Guideline update, they allow intervals up to 9 days in pregnant patients who are receiving treatment for later unknown duration syphilis. As of right now, the California Department of Public Health has elected to maintain their more stringent guidance that 6 to 8 day intervals are the maximal intervals that are considered acceptable treatment in pregnancy. That is under review, I can tell you, at the state level, but for now there is no plan to change it. Now, stay tuned for the future.
Great, thank you, Kelly. And for those who may be joining from other states, you should check with your state to see what they allow in terms of flexibility of dosing in pregnancy.
It's a really good point.
Okay, so thank you so much, Kelly. I really appreciate your time today and giving us that great overview of syphilis. Let's see, I'm just gonna share my screen here.
Sure, I will stop my share. I'll just say thank you all for having me again. I think you're going to a break soon after me, but I want to give a teaser that the next speaker is Dr. Ina Park. You've heard her name a lot, and I hope you'll stick around for her talk. She's wonderful.
All right, and I'm just gonna share my screen again. Here we go, okay. So yes, we're going to move to a quick break. So please plan to return at 10:50 a.m. for our next talk with Dr. Ina Park, covering updates to the CDC STI Treatment Guidelines. And we will see you here at 10:50. Thank you. Hello, welcome back. I'll give one more moment for people to join.
Should I share screen, Allison?
Am I sharing my screen now?
No, I'm saying, should I share mine?
Oh, I'm going to introduce you first.
Okay, perfect. Forgot about that.
Hello. Okay, welcome back, everyone. This is the STI Clinical Update with the San Francisco Department of Public Health and the California Prevention Training Center. And it is my great pleasure to introduce Dr. Ina Park. She is a professor at the University of California, San Francisco School of Medicine, medical director at the California Prevention Training Center, and a medical consultant for the Centers for Disease Control and Prevention, Division of STD Prevention. Dr. Park was a co-author of the 2021 CDC STI Treatment Guidelines and a contributor to the first federal STI strategic plan. She is also the author of Strange Bedfellows, Ventures in the Science, History, and Surprising Secrets of STDs. Her writing has also appeared in the New York Times and Scientific American. And with that, I will hand it over to you, Ina.
Okay, let me share my screen. Okay, can you see that, Allison?
Looks
Give me
good.
a thumbs up. Okay, great. It's always a miracle when technology works in your favor. So well, I'm really happy to be here. I know that there are folks from all over San Francisco in different healthcare settings, as well as I got messaged from some folks from out of state. So aloha to our friends in Hawaii who joined as well, and folks as well throughout California. So I'm going to be talking about the new CDC guidelines in the context of some cases. And for that reason, I had to prioritize. So if I left out your favorite STI, I apologize in advance. But we're going to start with a case of vaginal discharge. And this is a 40-year-old cis woman who's got itching, malodorous discharge, and some mild dysuria, and has one male partner who she thinks is with other partners. And so let's say her pelvic exam, you see some frothy discharge with an elevated pH, a positive lift test, but no cervical motion tenderness. So here's the appearance of the discharge, and you can see lots of bubbles, a little yellowish characteristic there. So let's say you do a wet mount because you have access to that, and you see more than 5 whites per high power field, but no clue cells and no trichomonas, and the KOH prep was negative for any fungal elements. Well, what could be going on here? When you see that sort of foamy, bubbly discharge, trick might be something that comes to mind, but you don't see trick on the wet mount. Well, that happens because the sensitivity of wet mount is very poor for trichomonas detection. So it's basically a coin flip, but 55% sensitive. And even in really optimal settings with very highly trained folks, it really doesn't ever get above 70% sensitivity. It's got great specificity. So if you see the trichomonas, sort of jerking around there, then you can believe the diagnosis. Culture is a little bit better in terms of sensitivity. Again, it's not great. And then nucleic acid amplification testing, or NATs, have actually been approved for over 10 years now. And you can see that the sensitivity is quite a bit higher. And again, excellent specificity for all of the trick detection methods. So again, we have a poor sensitivity test, although it's very satisfying when you do see trick on a wet mount. And then the other issue is, as many of you know, that the motility of the organism declines over time. So you want to collect a specimen and then look at it right away. And so in studies that have looked at the declines in motility, you have a decrease of 3 to 15% every subsequent hour after the first hour. You actually still have pretty decent motility and visibility after 60 minutes. But if you can't use microscopy within 60 minutes, it's better to use another method. And if you have access to nucleic acid amplification testing, you should use that anyway because it's very sensitive. But of course, it is nice to give results at the point of care when you can. So here's some other findings that you might see. The one in the middle is sort of that foamy, frothy discharge. It can have different appearances, different example here on the left. And then here on the wet mount, this is a very busy wet mount that actually has both yeast buds and trichomonads and white blood cells, as well as squamous epithelium. And then here are some findings that you might see when you're doing a pelvic exam, and you can have cervicitis due to trichomonas, and you can also get the sort of punctate hemorrhages underneath the surface of the cervix, which is referred to as a strawberry cervix. Doesn't happen very often. I've only seen it twice in my career, but does happen. And just to point out, actually CDC just this year put out brand new estimates for incidence and prevalence for all of the STIs. And for trichomonas, they estimated that about 2.6 million folks actually have trichomonas currently, with an incident infections of about almost 7 million per year. And you'll see that the age distribution of trichomonas is a little bit different than for gonorrhea and chlamydia. Tends to skew a little bit older, whereas gonorrhea and chlamydia tend to skew towards women under the age of 25, when we're talking about folks with a vagina here. So it is the most common non-viral STI behind HPV, and it is not reportable in the US. And the prevalence in different populations varies. So it's 3% overall, and this is studies done primarily in cis women. It is 15 to 20% in African-American women between the ages of 30 to 50. And then again, very high rates in incarcerated women, as high as 30%, as well as men. So high, in fact, the CDC actually changed their guidelines this year in July to say that there should be opt-out screening for folks coming into corrections who have a vagina who could be at risk for trichomonas. And just another take-home point about why we should care about this organism is that trichomonas does increase the risk of HIV acquisition. This is a systematic review, and this sort of summary statistic here is that it increases risk by about 1.5 times. So back to our case, lots of whites, no clue cells, no trichomonads. Could she have trichomonas, and how can we find out? So, we can order a nucleic acid test, as we mentioned. And let's say it's positive. So what treatment should she get, and what about her partner? So the entire theme of my talk, again, is better and, more treatment for longer duration, and in some cases, both more treatment and longer duration. And so my punchline here is that single-dose metronidazole is not as effective as 7-day therapy. Now, this is not necessarily due to the development of new levels of antibiotic resistance or something new going on with the organism, but this is just a deeper understanding of cure rates based on randomized clinical trial data that we didn't have before. So this trial was done by Patty Kissinger over at Tulane and randomized over 600 women to single dose versus 7-day therapy. And they did cultures for test of cure. The reason why they didn't do NATs is that you could get a positive NAT up to several weeks after treatment, and therefore they didn't want to have false positives. So take home point here, the cure rate, even with 7-day therapy, was not over 90%, but there was a statistically significant difference between 7-day versus 1-day therapy. So 81% cure with single dose and 89% with 7-day, hence leading to the recommendation that we should use 7-day therapy. So you will see for anyone with vaginal trichomoniasis, regardless of their HIV status, folks should get 7 days of metronidazole twice a day. Now, for folks who have a male partner, the recommended therapy is still a single dose of metronidazole, 2 grams. And the alternative regimen is tinidazole. And ACOG, by the way, had changed their recommendations last year to reflect what CDC actually did this year. And make sure to test folks for reinfection at 3 months, because many folks do get reinfected and would require then the same treatment they received before. This is one of my favorite things in the new treatment guidelines, is a new recommendation around metronidazole and alcohol. So there was a systematic review done by the Norwegians in Norwegian. And so the whole thing had to be translated into English, looking at both in vitro studies and clinical studies, looking to see if there was actually a relationship between metronidazole and inhibition of acetaldehyde dehydrogenase, which is inhibited by medications such as disulfiram and can cause, flushing, nausea, vomiting, and obviously a severe adverse reaction. So based on this review, there were actually no data to reflect that this actual sort of wives' tale that we've been telling for about 50 years around this. So the CDC guidelines now say you don't have to refrain from alcohol during treatment. And I will say, though, we all know, those of us who've prescribed metronidazole, that folks can have nausea, vomiting, and GI distress from either drinking too much alcohol or from taking metronidazole. So I think if you're having any of those symptoms, don't go there. But if you're feeling great, it's okay to have a glass of wine with your flagyl. And so what if someone fails treatment? And so if you look in the treatment guidelines, you will see some treatment recommendations for folks who may fail because they have low-level nitroimidazole resistance. And assuming someone did not get reinfected, you essentially up the dose of metronidazole or tinidazole, and you're giving 2 grams actually daily for 7 days. If there is continued failure, you can get a culture kit from the CDC, and actually you can call the San Francisco City Clinic. They also have access to trichomonas culture. So if you're in San Francisco and you need to send someone over for trichomoniasis treatment failure, you can. And I will actually show you a little bit later the phone number for the provider line, and you could call and talk to somebody if you happen to be in San Francisco. And then you can see there are other sort of salvage regimens. If this sort of daily 2 grams of metronidazole for 7 days doesn't work, which involves escalating doses in addition to intravaginal medications as well. The last of which is intravaginal promomycin, actually has to be compounded and can cause vaginal ulceration. So it's sort of a treatment of last resort. So I just want to show off the healthy vagina and transition over to somebody with penile discharge. So this is a 20-year-old cis man who has sex with men and women who has dysuria and urethral discharge for 2 days. So let's say he's received oral sex from 3 male partners and 1 female partner and has had inserted vaginal sex with a female partner. So his female partner texted him she had an STI, but didn't actually specify what it was. And then he does have some clear discharge visible at the meatus. So when someone, sort of walks in with this sexual history, these exposures, how would you choose to treat urethritis? So I'm going to launch a poll. Do we want to give this person metronidazole 2 grams because we think maybe he's got trichomoniasis? Do we want to give moxifloxacin for a week as well as treatment for trichomoniasis? Maybe he's got MGen and trich. Do we want to give him doxy? Do we want to give him azithro? Or do we want to treat him empirically with ceftriaxone plus doxycycline? And I'm not allowed to vote for my own question, so I won't do that, but I'm going to wait for you guys to finish up. And let's close the poll and see what you decided to do. Okay, so, and there's some style differences here, and that's totally fine. Some people, if we're taking the top 2 answers, some folks said, I'm just going to treat empirically for maybe chlamydia and give doxy for NGU. And some people are saying, this person said he was exposed to an STI and I don't know what it is. I'm just going to treat for GC and chlamydia potentially. And I think that, either of those are acceptable. And I think you need to look at, gee, I'm in a setting where we see lots of gonorrhea. I really want to treat empirically. And so let's say you were treating empirically for GC and chlamydia because you hadn't ruled either of them out and you're sort of doing syndromic management at this point. Those of you who have access to gram staining because you're working in an STI clinic setting are fewer and further between. So if you're treating empirically, you want to give ceftriaxone 500. That is double the dose of what was used in the past. The co-treatment with azithromycin has been dropped. If chlamydia has not been excluded, then you actually want to treat for possible chlamydia with doxycycline for 7 days. And the reason why we dropped azithromycin was due to increases in antibiotic resistance. About 5% of isolates have reduced susceptibility to azithromycin when looking at the national surveillance data. Okay, so now the test of cure. So the test of cure is not recommended for anyone other than folks who have pharyngeal gonorrhea, unless you're treating with a non-recommended regimen. And the treatment window, the test of cure window is 7 to 14 days, but do yourself a favor and wait 14 days. And that's what the San Francisco guidelines are going to say, and folks who may actually be diagnosed at City Clinic can get a pharyngeal test of cure kit to take home with them. And again, we ask people to do that at 14 days. And the concern being that you might pick up residual nucleic acid earlier than 14 days and give yourself sort of false positive result that you have to chase down. So let's say the patient comes back 10 days later and the discharge never really went away. And he swears up and down there's been no sexual exposures. And now you have test results back from your prior visit that were negative for gonorrhea and chlamydia, and the person still has discharge on the same. Now what do? We have someone who's got a urethritis treatment failure. Let's launch another poll. Are we repeating the treatment with ceftriaxone and doxy? Are we now treating for trichomonas? Are we giving a week of moxifloxacin potentially for mycoplasma? Plus treatment for trichomoniasis? Are we giving doxy plus moxy for potential mycoplasma? Or would we like to test and treat based on those results? Okay, let's see what your opinion is here. Okay, most people would love to do a test if they have one. I just want to acknowledge, of course, that not everybody has access to mycoplasma testing yet. For those of you who are on this webinar from San Francisco and don't yet have access, if you're in the San Francisco Health Network, I want you to know that folks at SFDPH are working hard on getting you access, and you will have that. And we will let you know. The folks like Stephanie Cohen and folks will let you know when access is more widespread. So, yes, Mycoplasma genitalium. So bacterial STIs obviously cause urethritis, and GC and chlamydia are right up there. There is a range quoted in different studies, and I highlighted that 25% there for Mycoplasma genitalium deliberately because I'm going to show you a study that actually reflects that, and actually even a little bit higher prevalence. And then of course there's other etiologies. Trichomonas vaginalis, more common in the South than it is in the West, but certainly can happen for any man who has sex with women, or someone with a vagina who might have trichomonas. And then of course, herpes can actually cause urethritis, as well as ureaplasma, and then actually respiratory viruses, as well as enteric. So lots of things can cause urethritis. And many times we don't actually have an organism for diagnosis. So in terms of this persistent urethritis, we want to document that the discharge is there and rule out any sort of non-compliance, which, as we know, as we're going to longer therapies, can be a bigger issue. And then obviously the biggest sort of factor here is untreated partners and reinfection. But I want everyone to put Mycoplasma genitalium on the top of their mind. And then of course, consider Trichomonas vaginalis. And if you have access to nucleic acid testing, please get that. And if you don't have access to that, but you have access to culture, you can do that as well. So I feel like this happened really quietly. This happened in 2019, and then the pandemic happened. So nobody cared about Mycoplasma, but there is a nucleic acid amplification test. There's actually at least 2 manufacturers that I can think of right now who have an FDA approved NAT for Mycoplasma. You can see that for folks with a vagina, the vaginal specimen, self-collected vaginal swab has the best sensitivity, and urine and endocervical swabs are actually worse. And then for males, urine has great sensitivity, not as good as vaginal swabs, but not bad. And there's also urethral and penile meatal swabs that can be either patient collected or clinician collected. Specificity is excellent for all of these specimen types. And so let's say you do a NAT, trichomonas is negative, and Mycoplasma is positive. Now what are we going to do? Well, so just a brief about Mycoplasma genitalium and how I would like you to think about it is it's sort of in between chlamydia and gonorrhea in terms of prevalence. So not quite as common as chlamydia, but it's actually more common than gonorrhea. And this is looking at young adults from the Ad Health study, which is a national study. And then if we go to STI clinics or emergency departments, you'll see that the sort of prevalence of infection is quite high. And then from a recently done study, the Magnum study, which was looking at folks in STI clinic settings, remember I showed you that 25% earlier, they found about actually 28% of folks with a penis who had urethritis actually had Mycoplasma. So it's really common. And so I want everyone to be thinking about it. But screening is not recommended. Right now, we don't know the value of screening asymptomatic folks for Mycoplasma. I'm going to show you that the treatment is very extensive. And from a stewardship standpoint, we don't want to be giving folks lots of antibiotics unnecessarily when we don't really know what the implications are for asymptomatic screening. So when to test is, this case is a perfect example. Someone had persistent urethritis. They failed the initial empiric therapy. Just so you know, it is also associated with persistent PID and cervicitis. It has been detected in the rectum, but whether or not there's actually a true relationship to proctitis is unclear. And it's not thought to be significantly associated with pharyngeal infection. And certainly pharyngeal testing is not recommended, and the NATs are not FDA approved for use in the pharynx or the rectum. So I told you the treatment is pretty extensive, and what we do for suspected or documented Mycoplasma is to start with a week of doxycycline to reduce the bacterial load. The thought here is that doxycycline would not typically cure Mycoplasma because there are very high levels of antibiotic resistance, but to help reduce the bacterial load, and then to give moxifloxacin daily for 7 days. And I will tell you, having prescribed this to people, they are dismayed at having to take antibiotics for 2 weeks. But unfortunately, I'm going to show you some data later. That's really where we're at right now in terms of having to use a long course of therapy to ensure microbiologic cure. So if for some reason you have access to resistance testing, which is really only being done in the context of research, although the company that makes one of the assays to determine resistance to azithromycin is actually going to go through the FDA approval process. If you know that you have a sensitive organism, then you give doxycycline, and then you follow it with extended dose zithromycin. So you're giving 1 gram on the first day, and then 500 milligrams every day for 3 days. But for the vast majority of us, we're going to be going with that first regimen, which is a 2-week course of therapy with doxy plus moxy. And this is from the Magnum study that I showed you earlier. We know they had 28% of their folks with arthritis had MGen, and over 50 to 60% of those folks had resistance mutations to either azithromycin, which is in the blue, to fluoroquinolones, which is in the green, or to both, which is in the yellow stripe over there. And my point is that simply having the presence of a resistance mutation doesn't mean automatically that you're going to fail therapy, but in many cases, there is a correlation. And so this is disturbing, I hope, for everyone, that what we're dealing with right now is some fear that Mycoplasma genitalium is going to be more and more difficult to treat. And we have certainly seen treatment failures already with moxifloxacin, which is the recommended regimen. If that happens to you, I'm going to show you a number later for the provider line at City Clinic. Please call it. I'll just say it right now and I'll show it to you again later, but it's 415-487-5595. I have it burned on my brain. Perhaps Allison can put it in the chat. So don't panic, but give folks a call at City Clinic, talk to a provider to tell you what's been used nationally. Minocycline has been effective in small case series. And when I mean small, I'm talking like less than 5 people. So I mean small. We're talking 14 days of therapy still with 100 milligrams BID. Then I wanted folks to be aware that there is also a novel antibiotic class called pleuromutilins. This drug, lefamulin, is actually approved for community-acquired pneumonia. It's being used off-label for Mycoplasma. It's 600 milligrams BID for 7 days, but the person should get pre-treated with doxy for 7 days. You can get it for free for your patients through the University of Washington through a study. And there are other resources. We've actually compiled sort of a cheat sheet for folks that we'll be putting at the California Prevention Training Center. We'll be publishing that soon. And if you have a treatment failure case and you're not in San Francisco, please put it into the STD-CCN, the STD Clinical Consultation Network, and we will help you out. And we did talk about gonorrhea because he got treated empirically for gonorrhea and chlamydia. Well, what if this had been a GC treatment failure? What would you have done? Number one, this I'm launching a poll, panic. No one's going to panic, right? But repeat the ceftriaxone, give a double dose of ceftriaxone. How about let's give 2 grams of azithromycin, get a culture, or more than one of the above? Okay. Let's close our poll and see what you said. One person panicked, so do not panic. I'm going to tell you what to do, and I am here for you. Everybody else said, maybe I'll repeat treatment, maybe I'll just get a culture and not empirically treat, or maybe I'll do more than one of the above. Okay, well, I have some actual guidance for you. And this guidance is for folks who are in the state of California. Please check with your state to see how they would like to manage these cases. But in the state of California, please get a culture, and actually anywhere you are, get a culture and get a nucleic acid amplification test, just to verify that we're dealing with a treatment failure. If you're in the city and you can't get GC culture, then you can send the patient to City Clinic, or you can call the provider line. And I told you I would show it to you, and here it is, 487-5595. Call and ask for help, so no need to panic. The state is actually recommending, if you have a way to verify that the patient has gonorrhea, to repeat the treatment, to give ceftriaxone double the dose, 1 gram, and actually give 2 grams of azithromycin. Or the other alternative therapy, which CDC endorsed in the last iteration of the guidelines, is gentamicin, 240 milligrams, and azithromycin 2 grams. We have gone through these sort of panic like alerts, for potential treatment failures, and then some of them have turned out to be reinfections. And in those cases, you can just give ceftriaxone 500. SFDPH actually changed its reporting number. So if you're looking at old documents from SFDPH, the reporting number there actually is not working, but this is the new reporting number. If you're in the city, here it is. It's a 628 area code and 217-6653. For those who are our guests from other states, please contact your local health department. I'm sure they're going to want to know about a true GC treatment failure. Test and treat all partners within the past 60 days with the same regimen as the patient. And again, the test of cure recommendations that we talked about earlier. The other thing I want to tell you about, and again, everyone will get access to these slides, but that the California State Health Department and our training center actually co-branded guidelines for gonorrhea treatment failure and management that are more extensive than what I've shown you here. Here is the link below. Go and check them out, please. And the other thing, I don't have time to talk about disseminated gonorrhea, but I wanted folks to know that in 2020, there was a cluster in the Central Coast of about 30 cases of disseminated gonorrhea. And now that has certainly grown and is no longer confined to the Central Coast. There's actually been cases all over the state. There's actually going to be a Dear Colleague letter for folks in California coming out very soon, detailing everything that's been going on with disseminated gonorrhea. But for now, the state and the California Prevention Training Center put out a fact sheet for disseminated gonorrhea. Excuse me. And you can see the link down here below at the bottom of this slide. So check it out. This is just filler. This penis just showed up at our clinic and I had to take a picture with it. This actually is the Healthy Penis who promotes awareness of syphilis among MSM. And you can actually get inside that costume and walk around. So, I'm sorry, the animation here got a little bit screwed up, but my third case is about a teenager who wants an STI screen. So let's talk about Talia, who's 15, she's cisgender, and she has no significant past medical history. And she's become sexually active in the last year and she's had 2 partners. So yes, I'm wondering how old they are. And so I'm sorry, my animation went out of order. We want to know if there's any sort of coercion, there might be any intimate partner violence. And I just want to alert folks that in July of 2021, when the CDC released the new treatment guidelines, they also released a companion document around taking a sexual history. And the National Coalition for Sexual Health just released new videos that show great examples of how to do sexual history taking. I feel like some of the main changes are making the partners question the old sort of, do you have sex with men, women, or both? Which just sounds so like 1990s, is, sort of more expansive in terms of just asking about gender of sex partners and not assuming these very binary type of identities. And then the other sort of questions around practices and protection from STIs, such as using barriers and past history, are the same. But question 5 is highlighted in blue because it's a new question. Previously, the assumption was, what are you doing to prevent pregnancy, as if people didn't want to get pregnant? And so now the question is really about asking pregnancy intention, whether or not you're planning to become pregnant or not. So not assuming that pregnancy is a bad outcome for some folks. And the 6th P is actually not included in the taking a sexual history. I don't know that the CDC is ever going to talk about sexual pleasure, but when you have a close relationship with a patient, then they may disclose to you about sexual issues that they're having, pain, etc. And then one thing that is mentioned in the new document from CDC is about taking a trauma-informed approach. And the point is that folks who've experienced sexual violence, and we know many clients and patients who have, become triggered and upset when taking very detailed history. So if you notice that, to stop the history and just offer testing and see what the patient wants. So it's sort of like ordering off the menu. And, some sample language is sort of, I see this is hard. We can test your blood for syphilis and HIV, and we can order gonorrhea and chlamydia testing of all these places. And what do you want? And another, helpful sort of hint that a colleague gave me was what they do in their clinic is if someone's starting to get upset, they actually give them a urine cup, give them swabs, have them go off and say, collect whatever you want, and sort of tell them what they can test for. So putting the control back in the patient's hands if you feel like the sexual history is not going well. And so Talia was 15, can't you consent? So, I know there were providers here from outside of California. All 50 states and the District of Columbia actually allow minors to consent for services, but the age varies. And here in California, the age of consent is 12. And some states actually have no lower age limit at all. 18 states actually allow providers to notify parents if they want to, but no state actually requires that. And just so you know that this includes in California consent for diagnosis and treatment, as well as preventive services such as HPV vaccination or hepatitis vaccination. So let's say her partners are cisgender males. She's had oral sex and vaginal sex. It's possible they're also having sex with other partners, and her partner did wear a condom during vaginal sex, but she does not desire to become pregnant. And the sex was consensual, but she didn't, find it all that fun. It was painful, kind of irritating. So one thing I just wanted to point out, and the reason why it's highlighted is that it's a change, were that the CDC guidelines actually did include sort of expanded recommendations around screening for adolescents. So this particular patient did mention oral sex, did not mention actually having anal sex, but the new guidelines do say to consider rectal screening or pharyngeal screening based on exposure. And so I will point out that the citywide guidelines have not yet been updated to address this issue, but they definitely will be. So stay tuned if you're a San Francisco provider. There's still no recommendation to screen males who only have cisgender female partners. There's still a shared sort of decision-making that's recommended, but for the populations or settings that are sort of high incidence, so your teen clinics, STI clinics, family planning clinics, those folks should do routine screening, and no change to HIV screening recommendations. And really no change, there's no routine screening for other STIs recommended, but to consider sort of things like what's going on locally if you want to screen for trichomonas, and same with syphilis as well. Obviously young MSM and pregnant people who are adolescents should all be screened. So I just want to promote the local guidance for those of you who are in San Francisco citywide screening guidelines at the website below. And again, they will be updated with some language around extragenital rectal pharyngeal testing, but have not yet been updated to this point. So chlamydia and gonorrhea vaginal swab, don't need a pelvic exam. She can self-collect the swab. Let's say you did a pharyngeal swab and the vaginal swab was positive for chlamydia. So Dr. Bacon in the next segment is going to be talking a little bit more about chlamydia treatment. We do know that doxycycline and azithromycin are both options. Azithromycin was the preferred regimen. It is now flipped to doxycycline. But for someone like this who's an adolescent, and for other folks for whom you think a week of doxycycline is not realistic for them, consider a patient-centered sort of management and inquiry before you decide what treatment folks are going to use. And the main issue here around chlamydia treatment is that if rectal infection is likely or highly possible, then doxycycline is better because there is much greater efficacy. And we're talking more than 20 percentage points here. And obviously folks who could be pregnant should not be getting doxycycline and should get azithro. But again, in this situation, this is actually based on a client that I saw at City Clinic. So doxy is preferred in general, but again, do sort of a shared decision-making process. So I asked, this is not the patient's name, but it was a very similar situation. And she wanted to take azithromycin because she said there's no way I could bring a pill bottle home and my parents could discover it and ask a lot of questions. So she ended up going for azithromycin. And now when we get to partner treatment, I want to point out that this is the map showing the legal status of expedited partner treatment in the United States. And I want you to notice there are no red states anymore. So South Carolina was the last state to hold out, and it is now permissible in South Carolina. So it's either permissible or potentially allowable in all 50 states, as well as in Puerto Rico. So that's a huge policy win. And I want to point out for those of you who are in California, Senate Bill 306 was passed actually last month, which states that providers and pharmacists are not liable. So that is, liable for medical malpractice or lawsuits if they do provide expedited partner therapy. And can I just add a note, because the state of California at least approved EPT for use for chlamydia in 2001 and for gonorrhea in 2007. And during both times actually widely advertised a phone number and an email address for folks to report any kind of issues related to EPT. So they kept that going for about 10 years and nothing was ever reported. Lots of questions came in, but again, no reports of adverse events. So not to say that there can't be liability here, but now there will be legal protection in state law. Previously, the CDC said only use it for hetero men and women, and now they actually expanded to say also consider it for cis MSM. No comment on trans folks because of no data. But again, now that there can be shared decision making, I feel like we should just sort of expand that really for folks of all genders. And then we do know for sure that providing patients with medication to give to partners is the approach that leads to the highest rates of treatment. And we know partners, especially adolescents, may not fill prescriptions. And in the state, when they did an evaluation for family packs, they found about a third of folks who just got a prescription actually didn't ever fill it. And that was actually for primary treatment and not for EPT. So before I get into my resources or whatnot, I just didn't create cases for this because I was concerned about not having enough time and wanted to answer your questions. So I have a couple of miscellaneous updates. So in the theme of more and longer for duration of therapy, there is now a change to the recommended treatment for pelvic inflammatory disease, which is that metronidazole is recommended for everyone. In the past, there was this recommendation. So the primary drugs haven't changed, but there was a recommendation to say, let's give it with or without metronidazole, which I think everyone on this webinar would admit is not helpful, right? So there was a study called the ACE study that looked at over 200 women with PID and found that adding metronidazole reduced anaerobes in the endometrium. And even though everybody felt better during the follow-up period, regardless of whether or not they got metronidazole, when doing an objective exam, looking for cervical motion tenderness and pelvic tenderness, folks that got metronidazole had less physical signs on exam of PID. And so now everyone should be getting metronidazole for 14 days with PID. And I had this very juicy, interesting herpes HSV case that I went into, and I just didn't feel like we had time. But the punchline was, it was actually based on a patient that I saw who was tested for herpes and had a low positive value and actually ended up having a confirmatory test, which was negative. So in the new CDC guidelines, two-step testing for herpes should be performed. That's the recommendation. I just want to acknowledge that lots of folks don't have access to confirmatory testing because the two tests that are recommended are the Western blot, which is only available at the University of Washington, and the BioKit, which is a test that, as far as I know, no large commercial laboratories are currently offering. Now that may change, of course, now that the new recommendations are out. But I think the point for providers listening here is that if you don't have access to confirmatory testing, I just want everyone to know that there is very poor specificity of the herpes ELISA at low index values. So if you get a low positive with a value under 3, based on the data that I have seen, the specificity is going to be less than 40 or 50%, depending on the study. So again, sort of a coin flip, and we're sort of saddling someone with a long-term diagnosis. So if you have a low positive result, if you end up getting the test and it's a low positive result, let the patient know that this, is possibly and even likely a false positive. Trying to get access to confirmatory testing if you can. Folks who are using LabCorp, for example, as their testing provider for sendouts, they do have a herpes immunoblot. It does not use all of the same antigens as the Western blot, so it has some of the same issues with specificity. So it's not the same type of confirmatory test as a full Western blot or this BioKit. If somebody comes in and says, I was just exposed to herpes, we know that the actual window for seroconversion is longer than we thought previously. And so the recommendation for testing is actually 12 weeks after a suspected recent acquisition. And IgM antibodies can actually pop up obviously with a new infection, but they can also pop up with recurrences. So IgM testing of any kind is not recommended. And again, highlighted here in, with bright yellow is if you don't have access to a confirmatory test, first of all, think about whether or not you really want to do a test or not, and counsel patients about the high rate of false positives. And again, I would refer you to the CDC guidelines because there's an extensive list of the situations in which you should test, and most of those involve people that have symptoms or have been given a diagnosis and just need a laboratory confirmation. Okay, so I'm winding down because I want to have time for questions, and I just want to let folks know this is a repeat of the website that I showed earlier around treatment failure, that if you have a question, you can put it into the STD-CCN. Anybody who's on this webinar now can use this service. Now, of course, if you are in the city of San Francisco and you want to call San Francisco City Clinic, please do that. And I know that Stephanie Cohen wants to know about these treatment failure cases in the city when they're happening. Those of you who don't have that resource, please use the stdccn.org and send us your consult. Let us know how quickly you want a response. And myself and Dr. Johnson and quite a few other folks answer consults there, and we will get back to you as soon as we can. The other thing is that if you are someone who teaches learners or want to beef up on your STI knowledge, or you're just an STI junkie, the National STI Curriculum, STD Curriculum, actually has free CME, and you can go there and actually it's all being updated right now with the new guidelines. So if you just want to brush up, please explore that. And I just want to say thank you. These are the ways to stay in touch with me on email or social media. And I think we should probably take a few questions. I'm going to look in the chat.
Thank you, Ina. That was a tall task. You just covered a lot of information. I did compile some questions, so I'm going to start throwing them your way if you're ready.
Yes, and well, can I actually state the new, should we say the new number for the provider line? Or do you?
Yeah, I put it in the chat as well.
Oh, great. So everyone can see that. Okay, perfect.
It's
Yes.
628-217-6677.
Yeah, but
And
the
the
old
old
number is
number
still
will
going to
be-
forward to the new number at this
Yeah.
point.
It will. Okay, so let's go back and start with trichomonas. We did have some
Yes.
questions. Okay, so someone would like to know how you suggest testing for trichomonas in men, or maybe we should say people with a penis.
Yeah, I mean, well, the nucleic acid amplification test can be used on urine in men. So I think that's, if you have access to a nucleic acid test, that would be the way to go.
Great, thank you.
I mean, it is possible to see, in our particular setting at City Clinic, folks can also spin the urine and actually look at the urine microscopy, and you can actually sometimes see live trichomonads, but the more sensitive way to do it would be to get a urine nucleic acid test from from folks with a penis.
Great. And then regarding treatment in pregnant people,
Yeah.
would you treat a pregnant woman with 7 days of metronidazole if she's in her first trimester? And the person asked because UpToDate says to avoid metronidazole in the first trimester.
Yeah, this is a gray area. We actually gave this webinar for family practice providers, and it was something that came up. And right now, sort of what we came to, and again, this is just sort of Mike Pollakar and I talked about this, that we think that pregnant people should probably get the same treatment as non-pregnant people. But again, this isn't something that's like delineated in black and white in the treatment guidelines.
Okay.
But yes, I know, in general, that first trimester of pregnancy when organogenesis is happening, people are hesitant to do anything, you know what I mean? So, but at any rate, especially if the person is having lots of symptoms, then I think sometimes we just have to, there's a risk benefit.
Thank you. Okay. Last question on trick here. Any comments about why the recommendation for male partners is still single dose of metronidazole 2 grams instead of the 7-day course, particularly in patients or in partners that might present with symptoms, and considering that there's not a test available for trichomonas for men?
Yeah, I mean, there's no like sort of wet mount equivalent, right, for trichomonas in men to confirm the diagnosis, but there's no data. The reason why the 7 days was switched to folks with a vagina is because there was a randomized clinical trial. And so the reason why it's, a single dose in male partners is just because there's no data. And I think if some folks could give 7 days if they felt like, they were concerned, but again, also compliance is the issue. So that's just why it just didn't change. It's not because there were any data to say 2 grams in a single dose is better for people with a penis. It's just that we don't have any information.
Thank you. Okay, so as you can imagine, lots of questions about MGen.
Yeah.
So this is just a general urethritis question, but can use of sexual toys or masturbation cause urethritis?
Use of toys, like I'm thinking about like if folks were to like insert their penis inside of something, for example, you know what I mean? I can't see that as being a primary mechanism. Are they talking about, I wonder if that person can clarify, are they talking about insert of sex toys? And I don't think masturbation, alone would be thought to be like a primary mechanism for mycoplasma. So, but, if you're talking about insert sex toys and rectal infection, I mean, I think it's theoretically possible, but again, we shouldn't be really testing for rectal or pharyngeal infection because, unless your lab validated the test for that, because they're not FDA approved for those sites.
Okay. And then would you consider mycoplasma for recurrent vaginitis?
Yeah, I mean, I think, mycoplasma would really be more for recurrent cervicitis. I think if they, you should look and look at an exam. But if the person has recurrent vaginal discharge and you've ruled out everything else, it's good to get a mycoplasma test because even if you don't actually see the cervicitis, it's possible that the vaginal discharge is a result of the mycoplasma. So I think it's worth looking. And if you've ruled out other things, it's definitely worth testing.
So given that MGen is more prevalent than gonorrhea, why is there no recommendation to test at initial urethritis presentation?
Wait, I mean, can you say that again, Allison?
Sure. Given that MGen is more prevalent than gonorrhea,
Right.
I think from some of your slides that you were showing about maybe regarding urethritis, why is there no recommendation to test at the initial presentation with urethritis?
Oh, that's such a good question. I mean, right, it's logical, right, that if it's that common that we should be looking for it. I think one of the issues is we don't know, as we do with chlamydia and gonorrhea, that asymptomatic screening of, folks that can become pregnant prevents things like pelvic inflammatory disease, right, and adverse reproductive outcomes. So we know that asymptomatic screening helps. We don't know that that's true for mycoplasma. And we also know that it is very difficult to treat and requires 2-week course of antibiotics. So I think folks are saying if it's asymptomatic, maybe we don't want to know about it, kind of thing. And until we know that screening asymptomatic folks actually prevents long-term health outcomes, I don't see them changing that recommendation.
Okay, thank you. Okay, and so for pregnant people with MGen, can you sub in a Zithro for the doxycycline? And if so, how much?
For pregnant people with MGen?
Correct.
Yes. I mean, if you're going to do an extended dose of azithromycin, then do 1 gram the first day and then 500 milligrams for the next 3 days.
Great. Okay, so can a patient start moxifloxacin 48 hours after the last dose of the 7-day course of doxycycline, or does the patient need to restart the 7-day course of doxy? How much time is acceptable gap between the doxy and the moxy?
Yeah, this is a gray area. I think for something that short, it's probably, you probably don't need to restart. Folks, we just had this conversation yesterday with folks at CDC, and lots of times you're having a larger gap than that, like you're having a week or whatever. So in principle, in general, like if it's, more than a couple of days, to restart the doxy and then give the moxifloxacin. So in some cases, people are going to be getting a week of doxy, 5 or 6 days in between, and then actually getting a week of doxy and a week of moxifloxacin. So they're essentially going to be getting 2 weeks of doxycycline spaced apart and then a week of moxifloxacin.
Okay. Let's see. Okay. Okay, sorry, this is sort of building off that, a little different. If a person was already treated for presumed gonorrhea and chlamydia,
Yep.
as in the case with 1 week of doxy, and let's say you empirically treated with ceftriaxone, can you then just treat empirically with moxy if you can't test for MGen if the patient is still symptomatic?
That's what folks used to do. And that was the prior recommendation in 2015. If the person is still having documented symptoms and you don't have access to a Mycoplasma genitalium test, which I know not everybody does, then still if you're presuming a Mycoplasma genitalium infection, the recommendation would be to treat for the full 2 weeks again. So doxy plus moxifloxacin. That was the old recommendation, was just say, let me give a week of moxifloxacin on top. But now they're saying, if you think that it's Mycoplasma genitalium, you're treating for presumptive mycoplasma, give 2 weeks.
Okay.
It's a lot of antibiotics.
It's a lot of antibiotics.
Yeah.
And is there any recommendation for test of cure for Mycoplasma? And if so, how many weeks after the treatment?
If you are suspecting a Mycoplasma treatment failure, the recommendation would be, it's similar to chlamydia, to wait for at least 3 weeks before doing a test of cure.
Okay. We're getting some more questions about the pregnancy treatment for MGen.
Oh yeah, that's a disaster. I mean, that's a disaster because, nobody wants to give doxycycline or moxifloxacin during pregnancy. So, what you end up with is probably giving extended doses of azithromycin and hoping.
Okay.
The issue with staining, of, developing teeth is more of an issue with tetracycline, the other tetracycline antibiotics other than doxy, but still nobody wants to give it. So, I think you're probably mostly having to use azithromycin.
Okay. And then someone suggested, wouldn't it just make more sense to do a longer course of moxy, maybe instead of the doxy? I'm thinking that's what they're saying.
Yeah, but people, moxifloxacin is also, I think, moxifloxacin is also not recommended in pregnancy either. So it's, it's not a class D, but I believe it's a class C. So people, again, if that happens, I would say, please, put it into the STD CCN and give us a call and let's figure something out. Because we probably actually get our ID pharmacist colleagues and consult involved to see if we can figure out a good regimen here.
Okay, thank you for that resource.
Yeah, and then can I just give a case example? I just got consulted where they accidentally tested the patient. They accidentally tested the patient who is actually pretty close to term and found an asymptomatic Mycoplasma genitalium infection. And so actually we're going to retest the patient in 4 weeks after delivery and actually not treat until after delivery. We don't know actually whether or not, there has been a link to adverse birth outcomes, but the patient is also very hesitant to take any medication whatsoever. So didn't even want to take wouldn't even agree to take azithromycin. So, again, it's a discussion with the patient as well. And again, the doctor was really upset. I didn't mean to test for this, and then it just came back positive. So,
well, that segues perfectly to the next question, which you did allude to, but someone is curious if you could maybe discuss screening for herpes and whether that's recommended or not. So moving away from the MGen conversation.
In pregnancy?
No, sorry, not regarding pregnancy, just in general. Like, would you do a serum herpes HSV test as part of a STI screen?
Not for most people. It's category D from the US Preventative Services Task Force. And that is because the specificity of the tests is so awful. I mean, I think if we had better serology, absolutely, I think it's great for people to know their status. But given how poor the tests that we have are, I don't recommend it. I do recommend, though, if anybody has, any type of genital lesion, to absolutely get an HSV PCR, of that, because those tests are highly sensitive and highly specific and don't have those issues. But the serology is just so bad. I think really we're recommending it, it be reserved for very specific situations. And that would be like if somebody says, well, but I have a partner with herpes, you know what I mean? In those, like a serodiscordant partnership, and I want to know my status. And if you get a high positive, you can be pretty sure that the person actually has true HSV-2 antibodies. But when you get those low positive, those can result from someone having HSV-1, and the glycoprotein G actually cross-reacts between the two types, and you end up with a low positive HSV-2 test when you don't actually have antibodies.
Interesting.
And then, Allison, can I ask a quick question? Because I know Kelly and Stephanie are on, because I have worked with folks in settings who validated the trichomonas NAT for male urine, but I'm actually just wondering, because I can't remember if it's officially FDA approved. So if Kelly or Stephanie or Oliver can jump in.
I know my understanding is the urine is not gender specific.
That's what I thought as well. I just wanted to double check that. Okay, thank you.
That's correct. Yes.
Yes. Okay, Allison, more questions. I see things coming into the Q&A.
Okay.
I'm not looking, I'm delivering.
What about oral chlamydia screening? Still not recommended, correct?
Still not recommended. Oh my gosh, that was a huge fight. Stephanie was probably there, so she remembers too. But people were irritated because it's always bundled. You can't, you often can't suppress the results. Why can't we just say screen everybody for chlamydia also with the throat? It is much lower prevalence. When you look at even folks who are like populations of MSM who have lots of partners, the prevalence of chlamydia compared to gonorrhea is, substantially less. Like if we're talking 10% in the throat, then it's like, a couple percent at 2% or something. Like the difference is pretty stark. So CDC felt like it's not worth routinely recommending pharyngeal chlamydia screening, even though they understand the tests are often bundled. And if you see the result, no one is going to ignore it. So, they do recommend treating if you get a positive result, but they don't recommend screening for it.
And then this person had a follow-up, like, what if the person is symptomatic? And I don't know if they mean like pharyngeal symptoms.
Yeah, I think if they're symptomatic. Yeah, I mean, I think if someone's got pharyngeal symptoms and you are suspicious that this is related to sex, I think testing, and then you're not really screening, you're doing a diagnostic test and you're seeing. But again, chlamydia is not likely to cause symptoms in the throat. If you're going to have symptoms in the throat from an STI, it's more likely to be gonorrhea, but I think it's reasonable to test for both.
Great. I think we're going to make it through our last two questions here.
Yay.
What about expedited partner treatment for syphilis?
It's not recommended. I mean, doxy is so hard to comply with. And, Kelly Johnson's presentation, you saw for early syphilis, the treatment would be 2 weeks. And so for expedited partner therapy for syphilis, we're not recommending that. Please have partners come in and get a shot of benzathine.
Great.
And I realize I want to go to my next slide so we can introduce Oliver.
Okay.
Shall I?
Yes.
All right. Well, it is my great pleasure to introduce Dr. Oliver Bacon, who is a friend and colleague at, and he is the supervising physician at San Francisco City Clinic, and he's an associate professor at UCSF in the ID division, and has led the RAPID initiative, which is immediate ART for folks newly diagnosed in San Francisco, which is part of Getting to Zero, and also worked with the capacity building assistance program at SFDPH as well. And I called him a prep road. He was on the prep road show, prep salesman. His areas of interest are obviously diagnosis and treatment of STIs, ART, and management of opportunistic infections. And he's done a lot of work in biomedical HIV prevention as well, and HIV testing, and he's just a wonderful person. And I'm so happy that he's leading the panel. Oliver.
Thank you, Ina. All right, so now I have to do this technical jujitsu and try and share my screen.
Yep.
Okay, here's this. Let's do this, and now change it to this. All right, are you seeing like the slideshow view?
We're seeing the notes.
Oh, crap.
So go to your top left display settings,
Yes,
hit that, and then swap.
swap presenter view and slideshow. Okay.
All set.
Oh my God, thank you so much. I wish someone had told me that a year ago. Okay, so welcome everyone to Cases from the STI Clinic. It's going to be a rapid ride, and I want to introduce, first of all, our amazing panelists. So we have Terry Marcotte, and Terry would like you to know that he's been a nurse practitioner at San Francisco City Clinic since 2014. Prior to that, he provided primary HIV care at the Positive Health Program, AKA Ward 86 at San Francisco General Hospital, where we actually worked together, particularly Friday mornings in urgent care. His clinical expertise is in sexual health, STIs, HIV medicine, and anal dysplasia. He also loves chihuahuas and chickens and is happy to be here. Next, we have Yvonne Piper, also a current colleague. She's a nurse practitioner at San Francisco City Clinic and is on the faculty of the California Prevention Training Center. She has been with City Clinic since 2015. Prior to that, she worked in PrEP research and in primary care focused on the needs of transgender and gender variant people. Outside of work, she can be found parenting her cat and her 60-something houseplants, or at the gym preparing for her next powerlifting meet. Hello, Yvonne. And electronically beaming in from Seattle, we have Meena Ramchandani, who is an assistant professor at the University of Washington in the Division of Infectious Diseases and is co-medical director of the Public Health Seattle King County Sexual Health Clinic, basically the City Clinic of Seattle. And we are super excited to have Meena here. And Meena and I work together on the Doxy PrEP study that Stephanie alluded to earlier, and we are on the adjudication committee. So we get to decide whether participants have an STI or don't have an STI, although we have no idea which ones got Doxy and which ones don't because we're blinded. So welcome, Meena. All right, here we go. So we're gonna try and get a couple things across in these cases. Some diagnostic approach and empiric therapy recommendations for proctitis, when to suspect ocular syphilis and how to make a diagnostic approach, which specialist help to get, and some therapeutic options when things are not ideal, how to do same-day start of PrEP in someone with a risk of recent infection, and then we're going to have a couple of tricky syphilis cases at the end, and the take-home message there is going to be how to interpret serologies in the context of the patient's history and exam. All right, and before we get going, really I've asked these STI expert panelists to talk about basically how they integrate the guidelines with the real world. We know that the guidelines are great, but the guidelines don't cover all of the tricky situations that we actually encounter in clinic. And sometimes you have to do the best with what you have, depending on your resources and depending on what has happened to the patient. So I've asked the panelists to keep that in mind, and I'm going to ask the audience to keep that in mind as well. So here we go. Case one, a 27-year-old cisgender man who has sex with cisgender men. He's HIV negative. He's taking PrEP. At his last PrEP quarterly visit 1 month ago, He was negative for gonorrhea, chlamydia, HIV, and syphilis. He's had 1 week of worsening rectal pain with some blood on the toilet paper, and he's seen some mucus on his stool. Sexually, he gives and receives oral sex. For anal sex, he tops and bottoms. He says, I think I may have a hemorrhoid. And on exam, he has a firm skin tag in the right anterolateral perianal region. And here is what that looks like. All right. That is not normal. Okay. So audience, we're going to do a little poll here. Let's see what you have at your fingertips. What diagnostic procedures are available to you? 3-site gonorrhea and chlamydia NAT testing, gram stain of rectal discharge, rectal swab for PCR of lymphogranuloma venereum or LGV or HSV, and then various combinations. Gonorrhea, chlamydia, NAT testing, and gram stain, or all three? Gonorrhea, chlamydia, NAT testing, gram stain of rectal discharge, and rectal PCR for LGV. So the panelists and I can't vote. We want to know what you have. Let's give it another minute or so. Okay, let's see what the poll reveals. So about a third of you can do NAT testing. 1 person can do gram stain of rectal discharge. All right. About 8% can do rectal PCR. And then actually, oh, interesting. So actually 46% can do all three. So that's reassuring. Okay, good. All right. So I think this case, I'm hoping this case will be helpful to you. People who don't have access to everything. Okay. So let's see, next slide here. Okay, so now another audience poll. So what would you empirically treat this patient with? So he has rectal pain, bleeding, discharge, and this funny looking mass. Would you give ceftriaxone 250 plus a gram of azithromycin? Would you give ceftriaxone 500 plus doxycycline for 7 days? Would you give ceftriaxone 500 plus doxy for 21 days? Or would you give that last regimen and add a cyclovir for 10 days? So tell us what you would do. All right, and let's see what the poll reveals. Okay, so 62% would give the current recommended ceftriaxone dose for gonorrhea, so 500 milligrams, plus doxy for 7 days. So that would be definitely an empiric regimen for proctitis, plain old proctitis. You're treating for gonorrhea and chlamydia according to the updated CDC guidelines. 20% would give, actually approximately equal number of people would give ceftriaxone plus an extended course of doxycycline, or that plus a cyclovir, and no one, thank you very much, no one would give the old regimen for proctitis, which it was the lower dose of ceftriaxone and a gram of azithromycin. Okay, so clearly people are getting up to speed. Some people think this guy has routine proctitis. Some people are worried about LGV and maybe even HSV. Okay, so panel, what would you treat him with? Who would like to take this one first?
I can take it.
Okay.
Well, here at City Clinic, we can do more tests than you can do at a general primary care clinic. So we would do a gram stain of the rectum and look for white blood cells and then base treatment on what we see. If we see any white blood cells with the gram stain, we treat for proctitis. And it's either just 500 milligrams of ceftriaxone plus a week of doxy, but we also have a sort of complicated algorithm about when we just go forward and give the full 21 days. But if I was out in a non-STD clinic where I couldn't do a gram stain and I was based on the symptoms, I probably would just go ahead and give them the ceftriaxone plus full 21 days of doxycycline. And then at that point, you can wait and see what his chlamydia test comes back as if his chlamydia test is negative, you could then follow up with the patient and tell him that he could stop after 7 days. But if chlamydia is positive, then I would just tell him to continue the medicine.
That is great. Thank you, Terry. And Yvonne,
Yeah.
any differences, and would you add acyclovir?
So I got really excited about that perianal lesion, and because we have a dark field microscope here, would be trying to dark field that as well. I would definitely get an HSV PCR from that lesion. I personally would have treated this person with numbers 2 and added the acyclovir, unless that rectal gram stain was really impressive in the terms of how many white blood cells I found. If I found a lot, then I would go for the 21 days of doxy. But yeah, depending on my gram stain, that would determine how much doxy I give him. But yeah, I absolutely would have included the acyclovir.
Got it. Do you have a white blood cell count threshold for when you might choose to give 21 days versus 7 days, or any other symptoms that might push you in one direction or another?
Yeah, usually if we have a really flagrant bloody proctitis, so if I noticed there was frank bleeding, if he was in so much pain that he couldn't handle anoscopy, those are things that would push me in that direction. And yeah, I'm desperately looking around my exam room trying to find our proctitis algorithm because I can't remember our white blood cell cutoff. But I think if I saw, 5 white blood cells per high-powered field or less, I would be less impressed. If I took a look at that rectal gram stain and it was so covered in white blood cells that it looked like urethral gonorrhea, that's when I would be more inclined to give the full course of doxy.
Got it. Awesome. Mina has joined us. Hello, good to see you. Thoughts on treatment of proctitis?
Yeah, that's a fantastic picture, and thank you for going through this case. I think about my differential diagnosis. So just to answer this question, I probably would do number 2, which is the ceftriaxone 500 and the doxy for 7 days, unless the patient had some risk factors that I think about LGV. So for example, if the patient's traveled and had sex with other individuals in other places where I'm concerned about LGV, if they have a high number of partners who have traveled, if they have a really friable kind of mucosa that's really friable. And one of our clinicians just showed me if the patient also has like an ulcer and buboes. So if you're thinking about lymphadenopathy, you're thinking more LGV, that would lean me towards doing the ceftriaxone and the doxy for 21 days as opposed to the 7 days. Now, that being said, it also depends on the patient population in terms of like, is this a patient I'm never going to see again? Or is this a patient that I can call or my chart, through the EMR and say, okay, at the end of 7 days, do you still have symptoms? If they still have symptoms, I might extend the doxycycline as opposed to, and their symptoms are getting better, as opposed to, no, their symptoms are completely resolved and the rectal chlamydia testing came back positive, then I might just do the ceftriaxone with doxy for 7 days if their symptoms are completely resolved. Other differential diagnosis, I love, Yvonne, you said, the dark field, we have access to a dark field too. I know all clinics don't, but that kind of also looks like either a chancre that has been secondarily infected with a bacterial infection of staph or strep. Sometimes I've seen that. And so I'd like to want to poke that thing and see pus comes out because then I'm thinking about staph and strep. We've had rectal or perianal abscesses from gonorrhea. So thinking about gonorrhea, perirectal or perianal abscess, and then condyloma lata. So that also looks like condyloma lata too. So I kind of smashed that thing with like a cover slip to try to see if there's any spirochetes that I could see on dark field. But that kind of goes through my differential. We don't have access to an LGB specific PCR. So in our clinic, we have to kind of just get from the history, get from the patient, and then also get from those symptoms. If the patient's symptoms improved, completely resolved after 7 days of doxy, and whether or not we extend the course or give the course. I'm not sure if I would give acyclovir right away. If there were more vesicular lesions or multiple lesions and kind of clumped vesicles, I would definitely do an HSV swab, PCR swab for HSV. That being said, if a patient had a lot of pain and I couldn't get a good endoscopy, I'm not sure if HSV is up there, I think that's like your clinical decision right there. Now, not to belabor this, but just doing a random HSV swab without vesicular lesions, I'd be worried about just picking up asymptomatic shedding and attributing, the symptoms to HSV when it really is like something else. So I think that it just can help your differential, but not necessarily giving the acyclovir right away if the patient presented exactly with that picture. That's making me think more gonorrhea or syphilis. And then the other thing on your differential, lastly, would be a thrombosed hemorrhoid. You always want to keep that in differential, although this picture really looks something more kind of pussy.
Wow. Okay. Thank you all three of you. That was amazing. And if I had a painful butt, I would definitely want to be seen by one of you. So I agree with everything everyone said. I think you could go either with the ceftriaxone plus a week of doxy or ceftriaxone and 3 weeks of doxy. I think this case is right on the borderline of garden variety proctitis versus LGV. There's some pain. There is this strange soft tissue mass at the anal verge. And I also totally agree. I would never, I tend to swab patients with proctitis for HSV when there's blood, when there's pain, but I would never use the presence of those symptoms to only treat for HSV. I think it can be there along with other things. You wouldn't want to you wouldn't want to be just treating asymptomatic shedding, as Mina said. Okay, so I did see this patient, and I will tell you that I did smash the heck out of that thing to get a dark field, and I did it twice. The poor guy, he let me do it twice, and I was fully expecting to see treponemes, and I didn't, and I was very frustrated. Okay, so proctitis. So proctitis is characterized by anal pain or discomfort, often purulent discharge, although not always noted by the patient. It can be bloody. One of the classic symptoms in the history is tenesmus, the urge to defecate, but being unable to defecate. This here, for those of you who haven't seen it, this is an anoscope. It can be inserted with a lot of lubrication, and you can shine a light down through, and it really allows you to look at the quality of the anal and rectal mucosa and to sample discharge very specifically when you see it. This is what you might see as you're looking down the barrel of an illuminated anoscope here. This is friable mucosa. It bleeds when slightly touched. And this is some discharge here, and you would aim your swab for gram stain or your swab for NAT testing right at that. And just a reminder, it is not normal. It is not normal to have any white blood cells in your rectum. So if the presence of one white blood cell, and this is a polymorphonuclear cell here, on rectal gram stain, the presence of one of these is a sign that there's infection or inflammation there. Okay. All right, so proctitis, what causes it? The most common causes are chlamydia, gonorrhea, and as Stephanie said, most rectal chlamydia and gonorrhea is asymptomatic, but when it's symptomatic, it's symptomatic. So chlamydia and gonorrhea are common causes of proctitis, and included in chlamydia is LGV, which we're going to talk about in a minute. Herpes simplex is another common cause. Rarely syphilis can do it, and the jury is really out about whether Mycoplasma genitalium causes proctitis or is a bystander. And there's a debate in the STI world about whether we should be testing for Mycoplasma genitalium in patients with proctitis, whether we should be screening for it in asymptomatic people at increased risk. That debate has not been settled. We're desperately trying to get a validated assay at San Francisco Public Health Lab using the MGen NAT for rectal testing as well. All right, so LGV is I call it the nasty cousin of chlamydia. It's in the family of serovars L1, 2, and 3. It's more invasive than the other serovars of chlamydia, which infect the columnar epithelium. LGV goes deeper, and it gets into lymphatic channels, infects macrophages, goes to lymph nodes. And so, as Mina said, you can get these inflamed lymph nodes regionally called buboes. The transmission is primarily sexual. Outbreaks in MSM started to be reported in the 2000s, and they were primarily LGV proctitis. Worldwide, LGV falls under the category of genital ulcer disease. You see these briefly ulcerated lymph nodes or briefly ulcerated genital ulcers that go away, and they're often on the sort of anterior genitals, on the vulva, on the penis. It can lead to chronic colorectal fistulas when it's proctitis. It can lead to strictures. It can lead to reactive arthropathy. And it can be accompanied by swollen perianal lymphoid tissue. That's a lymphoroid. That's what we saw in that photo a couple slides ago. And it really looks not unlike condyloma lata. And as I said, worldwide, there's probably more penile urethral LGV. It's characterized by a fleeting chancre followed by tender unilateral inguinal lymph nodes called a bubo. There's a very famous physical finding called the crease sign, where the inguinal ligament transects the lymph node there. You can also get these weird accumulations of lymphangitic tissue along the penile shaft called a bubonulus. So if you see someone who's sexually active, is complaining of dysuria or burning, and has a weird subcutaneous nodule on their penis, that is probably a bubonulus, and it's highly likely that is LGV. Okay, so panel. When do you work someone up for proctitis? What degree of anal symptoms buys someone anoscopy or a gram stain if it's available to you, rather than simply just plain old screening for gonorrhea and chlamydia? And given the resources at your clinic, what diagnostic procedures do you perform? I think you've actually already covered that. If you don't see white cells on a rectal gram stain, do you still treat for proctitis if someone complains of symptoms? I think you very nicely answered the question of when you send LGV PCR, if it's available to you. And what would be your approach to diagnosis and treatment if all you had was a history, an exam, and NAT testing with or without anoscopy? Who wants to go first?
I can go first on this one. You want me to go through all of these questions or kind of pick and choose a couple?
I would do question one, like what makes you work someone up for proctitis rather than just do a screening swab? And what would be your approach? And the last one. I think the first one and the last one are the most important.
Well, at City Clinic, we're able to do a gram stain in-house. So the fact that we've got this really readily available, I can grab a sample and be looking at it within just a few minutes. I have a pretty low threshold for working someone up. So even if someone just says it's been some itching or a mild pain, I'm inclined to work that up. And then if I did not have access to that, it would really depend on what I found on anoscopy, how much I would want to treat them. So I really go by either seeing on anoscopy friable mucosa or discharge, or if someone is in so much pain that I can't even do anoscopy, that's going to push me more in the direction of treat for LGV plus minus herpes.
Got it. If you couldn't gram stain, but you could test and you could, with or without anoscopy, what would push you towards empiric treatment for proctitis?
I would say any discharge, any friability, and then if someone is not able to tolerate anoscopy, those are all things that would push me. And I would hope in any of those situations, being able to send LGV has been really helpful. I've had patients with very unimpressive gram stains who end up having LGV. So yeah, I get surprised sometimes myself. It's not always as flagrant and symptomatic as what I think. Yeah, so anytime I've got access to that LGV PCR, I'm going to try to send it.
Got it. So Mina, you guys don't have access to LGV PCR. So if someone complains of a little rectal itching, what would you do?
Yeah, so with proctitis, there's a whole spectrum of patients like complaining of symptoms, from that really friable kind of bloody kind of mucosa to just a little rectal itching. I think if there's just a little rectal itching, I probably would swab the patient for gonorrhea and chlamydia. If they had any discharge that was concerning, we definitely take samples and we can look under the microscope for gram stain to evaluate for gonorrhea and white blood cells. But if they just had a little rectal itching, then I probably would just, sorry, okay. Sorry, someone was knocking on my door. If they just had rectal itching, then I probably wouldn't give the extended course of doxycycline for 21 days, unless that person specifically said on their history, like I was, abroad and having sex with multiple partners in areas where I do know that there are high rates of LGV.
Got it.
And Oliver, I would say just getting more specific about what they're actually feeling might be helpful too. So you have itching, and is it external? Is it internal? If it's external, do a good exam because there might be a lesion, there might be a rash, there might be fungus, there could be something more obvious and if it's not internal, I'd be less concerned about a proctitis.
I totally agree. And I was reassured. So if you don't have access to anoscopy or you don't have access to LGV PCR, I was very reassured by some recent findings that very mild LGV often responds to exactly the same duration of treatment that regular rectal chlamydia responds to. So in the randomized controlled trial of azithro versus doxycycline for rectal chlamydia that occurred up in Seattle and in Boston, there were some cases of very mild LGV that were discovered retrospectively that responded. 3 out of 4 responded to a gram of azithro, and 4 out of 4 responded to a week of doxycycline. So I think it is okay to risk stratify a little bit on the basis of someone's symptoms, but I agree with Yvonne. I've been fooled by cases of LGV that actually I would have thought were not LGV on clinical presentation. I will also add that before City Clinic, I worked at Ward 86, the HIV clinic, and our standard practice was if someone has really bad proctitis, we would just empirically, we would obviously send the gonorrhea and chlamydia nets, but we would treat with a longer course of doxycycline based on symptoms, and until we were able to actually order LGV PCR in more recent years, and that seemed to be successful. Okay, so
can I say one thing, Oliver?
Please.
So that being said, though, we do have access to the rectal chlamydia tests, which should test positive. So you could give the doxycycline for the 7 days. If the rectal chlamydia test becomes positive, then sorry, someone's really trying to get a hold of it. If the rectal chlamydia test becomes positive, then you could potentially extend the course if at the 7 days the patient's symptoms haven't completely resolved. And so that's another way to do it.
Absolutely, and I think that's undoubtedly that's what most practitioners wind up doing. Is kind of triangulating between the rectal chlamydia test and the patient's symptoms and how they are at 7 days. So we've actually basically covered diagnosis and treatment of proctitis. LGV clinical management, to quickly summarize, suspect it when patient has rectal pain with or without tenesmus, mucopurulent discharge with or without blood. You're going to order gonorrhea and chlamydia NATs, HSV PCR. If the rectal CT is negative, rectal chlamydia is negative, it is not LGV. Remember that. That is a very helpful test to have. Very rarely, you might order an abdominal CT if there's a concern for abscess or perforation. This can occasionally happen with LGV. It is a tissue invasive disease, but I would not routinely do imaging unless you're concerned for an acute abdomen. In San Francisco, LGV PCR is available through the public health lab for confirmation, but it's not available in a timely enough fashion to guide initial treatment decisions. And if you are in San Francisco and you would like to send a specimen to the public health lab for LGV, give us a call and we can help you do that. Obviously, the treatment is empirical pending lab confirmation of rectal CT. The treatment is 500 milligrams of ceftriaxone plus doxycycline twice a day for 21 days, or until symptoms completely resolve. Some patients will still be symptomatic at 21 days, and the rule of thumb is just keep giving them doxycycline until their symptoms go away. There's some limited trial data suggesting that a gram of azithromycin once a week for 3 weeks may be an alternative to doxycycline. Those data are sparse, and there are many good reasons why we are restricting azithromycin in the STD clinic in favor of doxycycline. And finally, if you are seeing a contact to someone with LGV in the last 60 days, unless they themselves have symptoms of either urethral LGV or rectal LGV, you can simply treat them as you would as a chlamydia contact with a week of doxycycline. All right, so this was, his rectal CT was positive, his rectal LGV PCR was positive, and at 28 days later, he was asymptomatic and that lymphoid had resolved. All right, so Ina wanted me to quickly cover updates to the chlamydia treatment guidelines. So really, the emphasis has shifted away from azithromycin and towards doxycycline. The recommended first-line regimen for non-pregnant persons with chlamydia at any site is doxycycline twice a day for 7 days. Azithromycin 1 gram has moved down to an alternative regimen. If pregnancy has not been ruled out in someone biologically capable of pregnancy, or if that person is not on highly effective birth control, it is still acceptable to give azithromycin 1 gram once. And also the alternative regimen in pregnancy is amoxicillin. All right, so why the change from azithro to doxy in chlamydia treatment? So there have been numerous meta-analyses of both urogenital and rectal CT treatment that have shown improved cure rates or decreased failure rates when doxycycline is used over azithromycin, and that's been seen in symptomatic urethral infections and in rectal infections. They're about equivalent in cervical infections, but the surprising finding that many people with a vagina actually have asymptomatic rectal chlamydia helped push the recommendation towards doxycycline because doxycycline is far more effective than azithromycin for rectal infections. And that was shown in a meta-analysis and also recently in 2 randomized trials that strongly favored doxycycline over a gram of azithromycin. And the treatment difference was really 20 to 26% increase in cure rates for doxy over azithro. There's also antibiotic stewardship issues with azithromycin, as Ina talked about. Rates of increased MICs to azithromycin have increased in gonorrhea, and we know that azithromycin resistance is an increasing problem in infections such as Shigella and in pneumococcal pneumonia. So for many reasons, the 2021 guidelines favor doxycycline for chlamydia over azithromycin. And I included those references down there if you want to look up the information for yourself. Okay, so case 2. This is a 42-year-old cisgender male patient referred by his male partner, whom you just treated for latent syphilis of unknown duration. The patient is in the waiting room. And this was a real case at City Clinic. And it was the medical student who was seeing the cisgender male patient, who was seeing the partner, who said, hey, his partner's in the waiting room. I think we should see him, based on what the latent syphilis patient had said. Anyway, our patient was diagnosed with HIV 5 years ago. He never took ART because he was scared of the medical system. We know nothing about he knows nothing about his CD4 count or his viral load. All we know is that he's never had pneumonia, meningitis, or thrush. On exam, he has a non-pruritic maculopapular rash on his torso and arms. He notes worsening blurry vision over the last 3 weeks and actually had to be escorted from the waiting room to the exam room because he couldn't get there on his own because he didn't know where he was going. He can see shapes moving when you wave your hands in front of his face, but that's really the extent of his vision right now. And the remainder of his cranial nerve exam is normal. So this is what his rash looks like. You might be forgiven for thinking it's livedo reticularis, but since we're in an STI clinic, it's probably not. So audience, we have a poll for you. What would you do? and your choices are order an RPR, perform a lumbar puncture for cerebrospinal fluid, send to the emergency department for immediate ophthalmologic exam and consultation, send the RPR and send the patient to the ED, or do all of the above, and give a shot of benzathine penicillin before he goes. So let's see what you decide to do. All right. Let's give it a few more seconds. Okay, so let's see what the poll reveals. So 62% would send an RPR, do an LP, send the patient to the ED, and give benzathine penicillin. I think that's great. 30% would order an RPR and send them to the ED for everything to be done there. I think that's fine. Okay, great. All right, so people, I think, are appropriately worried about this guy. Okay. So panel, so the patient is a contact to syphilis, is living with HIV, has a suspicious rash, and has recent decrease in visual acuity. How would you manage this guy? So what symptoms or findings related to the eye in general make you include ocular syphilis in your differential diagnosis? In this case, we don't have a reactive RPR yet. We don't actually know that he has syphilis. We don't have any confirmatory testing, right? Do you have an alternative explanation for his rash? Are you working in a place where you can obtain a stat RPR while the patient waits, which would be a nice confirmatory test? Would you trust a non-reactive RPR in this guy and stop doing workup and treatment for syphilis? So what would you do?
I would say I would do all of the above from your previous slide. I would do we can do a stat RPR here in the clinic, but if not, I would send an RPR. And I would treat him with bicillin before we sent him to the ER.
Mm-hmm.
I think that this issue of if you're concerned about neurosyphilis or ocular syphilis, I think clinicians sometimes are concerned about, should I give them medicine? Is that going to mess up the workup once they get to the ER? Is it going to mess up their LP? But we do it really to render them non-infectious, and it's not going to complicate what happens to them later on. So it's better to just do it, seize the moment while you can.
Thank you. I think that's a crucial point.
To address the part about trusting a non-reactive result, I think that's interesting in this patient because we have to think about possibility of a prozone reaction, meaning that the RPR is actually so reactive that we can't get an accurate result on that first dilution. So if that were the case, luckily our current lab manager can do some dilutions for us. In the absence of that, I would kind of assume a prozone. Given this whole picture, I would still treat this person and proceed with neurosyphilis workup.
Okay.
I think I agree with everything everybody said, and that is a beautiful rash. That's syphilis until proven otherwise.
Right.
Especially in a patient with potential risk factors for syphilis. Very concerned about the visual acuity. Patients can have a variety of symptoms for ocular syphilis. I've heard of floaters, spots, but the concerning thing is the decrease in visual acuity. And that's where I would kind of like jump on this patient, because if the patient has decreased vision loss, that could be irreversible if not treated early. I love giving the patient the benzathine penicillin just once before they go to the ER, because the loss of follow-up can be high, and the benzathine won't get into the eye, but at least it would help prevent secondary transmission if this patient were to have sex with someone else. So at least get syphilis out of the body, you know, but it wouldn't treat the potential ocular syphilis. Now, if you had asked me this question last year, I probably would have done all of the above. However, with the new guidelines, if the patient has no evidence of any cranial nerve deficits or any neurological complaints whatsoever, even though this is someone who has HIV and uncontrolled virus and may be more apt to get neurosyphilis. If this patient has absolutely no concerns for neurological kind of effect of syphilis on the brain, then I would just have the ophthalmologist to evaluate the patient, try to get an RPR. We have stat qualitative RPR testing, but that's such a beautiful rash. I would just treat the patient and get the opto. Now, that being said, we have been lucky. Our opto colleagues have been really wonderful about getting patients in within 24 hours. And so that's been really helpful, maybe potentially even avoiding an ER, visit. But that being said, with the decrease in visual acuity, I probably would treat this patient with IV penicillin. So kind of going from there.
Fascinating. And we're going to touch on some of those issues that you raised in a minute. I think sorry, Terry.
The other thing with the vision loss, he's untreated HIV. We have no idea if he could have more than one thing going on. He could have CMV in the eyes, or so. I just think but it's beyond what you can do in a clinic. So he needs to go get the most urgent eval he can, which is usually through the ER.
That's a great point, Terry. Thank you for bringing that up. We really know nothing about his HIV at this point. All right. So the stat RPR is reactive, but you've already sent him to the ED. He agrees to go reluctantly. Remember, he doesn't love the medical system. In the ED, they do obtain an LP. This was actually done before the most recent CDC guidelines. And we'll see if people change their practice of not getting an LP on these folks. I'll be interested to see if that happens. Anyway, it's flagrantly positive. So he has 80 white cells. So that's more than 5. So that's not normal. He has a high protein. He happens to have a reactive CSF VDRL of 1:16, but a non-reactive CSF VDRL would not change my diagnosis or my management one little bit. We know it's a very insensitive test. It's helpful if it's positive. It's not helpful if it's negative. And his serum and so he goes to a hospital where they use the reverse algorithm. Thank you, Kelly. And his TPALD and EIA is reactive in the emergency room. So one of the great things about using the automated EIA is you get the results back very, very quickly. He starts PEN-G 4 million units every 4 hours in the ED and is admitted, where ophthalmology sees him. A dilated slit lamp exam shows bilateral chorioretinitis. And his RPR, his serum RPR comes back sky high at 1 to 1024. Not surprising, he has secondary syphilis. That's the stage of syphilis where you're going to see the highest RPRs. His CD4 count is 1, and his HIV RNA is 450,000 copies. He makes a rapid improvement. On the morning of day 5, he can read day 5 of hospitalization and penicillin. He can actually read the ingredient list on the little cup of orange juice he gets on his breakfast tray. He agrees to start antiretroviral therapy. He's sufficiently freaked out by what's happened to him to really want to get things under control, but he's going out of his mind in the hospital. He says he can't stay and he wants to go stay with his partner in their RV, which is parked in Candlestick Park. And please, can you give me a shot or some pills? Yikes. This is like a medicine resistance nightmare. Okay. So just a quick recap. Treatment of neuroocular otosyphilis is aqueous penicillin for 10 to 14 days. An alternative regimen, if compliance can be assured, is procaine penicillin, daily IM, plus 4 times a day probenecid to keep the levels up. And remember, when you're treating someone for neurosyphilis, including ocular or oto, you want to make sure that they have the total amount of penicillin that they need to match their stage at diagnosis, okay? So remember, and everyone thinks that IV penicillin is absolutely the best. Well, it's great, it crosses the blood-brain barrier, but you only, it's only there when it's there. As soon as you turn off the IV pump, the penicillin is gone, right? And the beauty of benzathine penicillin is it stays around for actually 7 to 10 days. So if he had late latent syphilis and he got 10 days of IV penicillin for his ocular syphilis, you would want to make sure that he got a dose of bicillin the day his IV penicillin is turned off, and another dose of benzathine penicillin a week later. So remember, you want to make sure that the duration of total penicillin therapy matches the stage. And neurosyphilis is not a stage, it's a symptom. All right. So as Mina said, ocular syphilis can affect any part of the globe. So really there's a plethora of ocular symptoms that patients can report that would make me very concerned about ocular syphilis if they had evidence of syphilis otherwise on the basis of a newly reactive RPR or a rash or a chancre or other manifestations of primary or secondary syphilis. You can see it with a red eye, you can see it with floaters, you can see it with retinal nerve problems, and you can certainly see it with symptoms of anterior, posterior uveitis and decreased visual acuity. Okay, so this was some nationwide data from CDC looking at the demographic characteristics of patients with suspected ocular syphilis, and you'll see that being HIV positive was 51% of patients with ocular syphilis had HIV, and male sex and MSM exposure was also highly associated. And then these were the symptoms that were most commonly seen: blurry vision, visual loss, eye pain or red eye, and the diagnosis was most commonly uveitis. All right, so the diagnostic criteria for ocular syphilis are ocular signs and symptoms in a person who has syphilis. Most will have positive serologic tests. And as I said, well, in patients with late ocular syphilis, up to 30% may have a non-reactive serum RPR or VDRL, but will have a reactive treponemal test. That's something to keep in mind. We'll talk about that a little later. Up to 70% of patients with ocular syphilis will have CSF abnormalities, but that means that 30% of people won't. So a normal CSF does not rule out ocular syphilis. There were no treatment updates, changes in treatment recommendations in the 2021 STI guidelines. But as Mina pointed out, for ocular notosyphilis, the most important diagnostic maneuver is to get immediate ophthalmologic consultation. LP is not absolutely necessary in the absence of any other neurologic findings, particularly cranial nerve findings. So you're not obligated to get an LP unless there's any other cranial nerve abnormalities. Okay, also another important point. So repeated CSF exams are not necessary for patients with neurosyphilis who got an initial LP unless they have untreated HIV infection or meaning they're not on ART, or have other immunocompromising conditions, as long as they have serologic improvement in their RPR and clinical responses after treatment. So I think the most important take home really is that syphilis of the eye can progress very rapidly and cause blindness. The prognosis for visual return really depends on the shortest duration possible of time between the onset of symptoms and the onset of treatment. Someone can have profound visual loss at diagnosis, but if their symptoms have only been going on for a week or two and you treat them immediately, they are very likely to regain their vision. If the symptoms go on for too long before treatment, that's when they can suffer from blindness. Okay, so we have a guy who's day 5 of his IV penicillin. He wants to leave the hospital panel. What would you do next? Here are your options. And Mina, you guys up in Seattle do outpatient treatment of neurosyphilis with procaine penicillin. So I actually want you to comment on that first.
Sure. So we've been very fortunate in Seattle because we actually have 2 of our practitioners trained to do lumbar punctures as well in the clinic which makes things, I think, really helpful when, let's say you can't have the patient see ophthalmology, they refuse to go to the ED, and you kind of need to make a decision right then and there. The LP can help, because if you get that white blood cell count and protein, let's say if they didn't have HIV right away, it comes back within an hour, very quickly. It can help you in terms of clinical decision making. And it helped before the previous CDC guidelines when we did need to do LPs more often. And then, Oliver, to answer your question, we do use quite a bit of procaine with probenecid and have had fantastic results with that in treating patients with neuro, some of the ocular and oto cases as well. And Dr. Christina Mara had put out a paper looking at CSF abnormalities, showing that patients had, I think, normalization of CSF the same with procaine versus IV penicillin. Now, that being said, if a patient has like visual blindness, I think there's just more data with IV penicillin. And I would say most clinicians would probably send the patient to get a PICC line or to the admitted for IV penicillin. So in this particular setting, I just have a heart-to-heart with this patient and be like, listen, I know it's hard to engage in care, but you don't want to come back to the hospital and your vision's really important. Clinically, I would love for you to just stay in the hospital a few more days. If you're itching to leave for whatever reason, let's try to address those reasons, whether it's your housing, whether it's substance use, whatever it might be. Let's try to get you treated with this IV penicillin, because that's what I would do if it was me or a family member. And that usually has worked. That being said, if a patient completely refuses, I don't have too much data on the ceftriaxone, so I probably would lean towards the procaine because we have a lot more data on that, and we have that, and it's been wonderful. But then the patient has to come in every day, and who knows if they will. So my heart-to-heart is really what I would rely on, not necessarily a 51-50 hold, but a MENA hold.
All right, thank you. That's great, because I was really wondering, like, how far will you go with the procaine penicillin? When would you favor IV penicillin over that? So in the interest of time, I'm actually going to move us on. I'm going to skip over case 3 for now, since we're on a roll with syphilis, and go to the syphilis cases. And if we have time, we'll come back to case 3. All right, so some syphilis serology cases. This is Betty Davis. If you know the movie this is from, put it in the chat. So case 4, 32-year-old cisgender female. She's HIV negative. She's had pelvic discomfort and warts for a week. Her last period was 2 months ago, and her urine pregnancy test is positive today. She's had pay attention to the partners here. She's had 2 male partners in the last 6 months. Partner A, she started having sex with 1 month ago. Partner B, she stopped having sex with 4 months ago. She has no history of syphilis. Her RPR is 1 to 128, and her TPP is reactive. And on exam, she has these flat, moist, rubbery nodules at the introitus of her vagina. She has no medication allergies, and she hates needles. This is what her external genital exam looks like. That is not normal, in case you were wondering. Panel, what would you treat her with? Liquid nitrogen, are these genital warts? Bicillin, 2.4 million units IM once weekly for 3 weeks. Bicillin once, doxycycline for 14 days, or doxycycline for 28 days. Yvonne, I'm going to give this one to you.
Awesome, because I think that this might have been my patient. So I would do number 3, the bicillin 1 time, given that this patient is pregnant.
Yes. Yes, definitely. How would you stage her?
I would call that secondary based on those lesions. Those look like condyloma lata to me. The fact we've got a dark field, I could confirm that. But yeah, those look very condyloma lata-ish to me.
Yes. So if you don't have access to a dark field, that's what condyloma lata look like, and it is perfectly acceptable to make a diagnosis of secondary syphilis on the basis of that, as long as you confirm it with positive serology. I would do exactly the same thing, and because she's pregnant, I would not use doxycycline. I would use bicillin. Some people get very worried that if you have a pregnant person with syphilis and they've never had syphilis before, Could they possibly have late latent? Do you need to treat them weekly for 3 weeks? But we know that she has secondary, so a single dose of benzathine is absolutely fine. All right, so partner A is 28. He's a cisgender man, HIV negative. He was treated for syphilis 5 years ago. He had a sore on his penis. He remembers getting the bicillin in his gluteus. He's had 3 female partners in the last 6 months. His first sexual contact with the index patient was 1 month ago. He denies rashes, ulcers, and none were found on exam. He is stat RPR non-reactive in clinic, and he has no drug allergies. So Terry, how would you manage this guy?
I would definitely treat this partner since he has had recent contact with this patient who's got secondary syphilis. And you can't really rely on his RPR because it can take up to 3 months for it to turn reactive. So it's good to test, because if his last test was negative and his new test is positive, then you know he has syphilis. But if his test is negative, you can't rule it out. And so we would treat regardless of the test result.
Exactly. Do you ever have trouble convincing someone to do that?
Not really. I mean, if I just explain it like that, I tell them the sort of duration of how long the test might take, and that people accept it pretty much.
Got it. I agree. People get pretty freaked out when you tell them they might have syphilis. All right. So now partner B, 29, cisgender man who has sex with men and women. His last sex with the index case was 4 months ago. In the last year, he's had 1 male and 3 female sex partners. He had a rash on his chest, abdomen around Halloween 2 years ago. It didn't itch. He kind of blew it off and it got better without any treatment. His RPR in clinic is 1 to 8 and the TPP is reactive. His last RPR was non-reactive, and that was in the summer of 2019 before he had that rash. And he's never been diagnosed with syphilis to his memory. On exam, he's asymptomatic. There's no rashes, there's no ulcers. His cranial exam is normal, no hearing loss, no tinnitus, no floaters, no cloudy vision. He's fine. So, panel, anyone can take this one. How would you manage partner B? Would you give him bicillin once? He's a contact, right? Would you give him bicillin 3 times? And I'll go back to this because you need it to do some time calculations.
Yeah, I mean, I would say based on his, so there's multiple factors, but if you believe the story, then they haven't had contact for 4 months. So technically as a contact, he wouldn't fit this definition of a contact, so he would only need 1 dose. But because it's been so long since basically you don't know how long he's had this, because he's outside of the window as a contact, you'd need to treat him for 3 doses as latent syphilis.
I totally agree. You know he has syphilis because his RPR is 1 to 8 and his TPP is reactive. And the question is, how do you stage him? And yeah. Terry, I completely agree with you. He had a convincing story for secondary syphilis, but that was more than a year ago. So he's kind of lost his chance to be treated for secondary syphilis. And now we think he was infected more than a year ago and he needs treatment for late latent. Totally agree. All right, so key points here. Syphilis in pregnancy, penicillin is the only treatment. Condyloma lata are highly infectious and they're found in the anogenital region. Persons who have had this is straight from the guidelines, persons who've had sexual contact with a person who receives a diagnosis of primary, secondary, or early latent syphilis within 90 days preceding the diagnosis should be treated presumptively for early syphilis, even if the serologic test results are negative, because as you pointed out, Terry, there's a big window period for serologies. However, if the contact tests positive and the last sex with the index partner was more than 90 days ago, evaluate and treat based on stage, because they're not likely to have been infected by the index partner. And stage is based on symptoms and the history of the patient on the day you diagnose them. Remember, partner B probably had secondary 14 months ago, or actually 24 months ago, but he has late latent today. Okay, so we are almost out of time. We got to do this case though. 35-year-old cisgender man who's had sex with cisgender men and women presents to urgent care with dysuria and scant clear discharge. Bottom line is he has urine CT positive. his EIA is positive, his RPR is negative, and his TPPA is positive. Okay, so what do? Your choices are give him bicillin once, give him bicillin for 3 weeks, no antibiotics, rescreen in 3 months, or take a good history. So this is a reverse algorithm result quandary.
So I would say we need more history on this person. The picture that we are getting with that EIA and TPPA reactive means this person had syphilis at some point in his life. And we just need to figure out if this reflects an old treated case versus a never treated case, which could be either super early or it could be a late latent case.
Exactly. So this is a quick rundown of sensitivities of syphilis serologic tests. So the non-treponemal tests are less sensitive than the treponemal tests for early primary. Okay, so someone could have early primary and have a non-reactive non-treponemal test, and forcing the TPPA, or if you're in the setting where they use the reverse algorithm, getting an EIA is likely to pick that up earlier. Similarly, the treponemal tests stay positive for life, whereas the non-treponemal test can wane after some period of time. So you're in the situation where you have 2 reactive treponemal tests, the EIA and the TPPA, and a non-reactive RPR. This is either untreated early syphilis, and you want to get a good history, do a good exam, see if there are any recent contacts. This could be untreated late syphilis. So has he ever been diagnosed with syphilis before? If not, then, and there's no sign of early primary, then this is probably late latent. Or yes, he had syphilis 5 years ago, he got treated, he's fine. This is previously treated, you don't need to do anything. So the other situation you can run into is an EIA positive, negative RPR, negative TPPA. This is almost always a false positive EIA, and you don't really need to do anything, but if you're concerned this could be very early syphilis, you might want to re-examine and repeat the titer in 2 to 4 weeks. That is it. So thank you to the 3 of you for providing this incredibly expert and illuminating conversation. And Allison, I'm sorry, I don't think we have time for questions unless you allow us to.
Thanks for inviting me. This was really fun. I have to run to clinic, but feel free to email with questions. And it was so nice to meet everyone. So thanks for letting me participate today.
Thank you for agreeing to participate. And thank you, Yvonne and Terry as well.
Thank you, Oliver. I think we have 6 minutes. Maybe, should I throw out a couple questions?
Sure.
We did get a lot. I can imagine a lot of questions about neurosyphilis. So just a reminder, we will follow up in 2 weeks with all of the slides, a webinar recording, and a Q&A document of all the unanswered questions. But a couple people did ask, is hearing and vision loss related to syphilis usually unilateral, or can it affect both eyes, ears?
Yeah, great. Yeah, it's a great question. The answer is yes. It can be unilateral, it can be bilateral. The hearing loss in otosyphilis can actually be stuttering. So it can appear and disappear and appear and disappear, unfortunately. But yes, it could be either unilateral or bilateral.
Okay, thank you.
And just keep in mind that syphilis disseminates very quickly after primary infection. So it can occur in multiple locations in the body, and it acts like a vasculitis. So it has this sort of systemic flavor. So it would not be unusual for it to be bilateral in the case of ocular or otosyphilis.
Thank you. And you mentioned the 10 to 14 days of IV penicillin for neurosyphilis. And will that be adequate treatment if the stage of the patient is primary, secondary, early latent, or late latent?
It should be adequate therapy for primary and secondary. Early latent is tricky, right? Let's talk about late latent first. It is absolutely not adequate therapy for late latent. You want to make sure someone has at least 3 weeks of exposure to penicillin for late latent. I would most people get 10 days rather than 14 days of IV penicillin. So for people getting treatment for latent, I would always recommend that they get 1 dose of bicillin the day they're on the 10th day of their aqueous penicillin, and another dose a week later. For early latent, I tend to err on the side of caution and recommend to inpatient teams that the patient get a dose of bicillin the day their IV penicillin turns off if they got 10 days.
Okay.
CDC kind of gives you some leeway. They say should receive up to 3 doses of benzathine penicillin after finishing IV penicillin.
Great. Do you know if ophthalmologists, optometrists are trained to recognize ocular syphilis?
It's a great question. My clinical experience is that they are. And they err on the side of caution. Ophthalmologists, definitely. What they're looking for is uveitis or any of the other manifestations of syphilis in the eye, and they are. My experience is that they're able to do that. Optometrists, I don't know that much about their training.
Okay. Well, thank you. I think that brings us to our close today. So just a reminder for our CME requirements. And thank you all the panel members. That was really exciting to hear from everyone. And thank you, Oliver, for moderating that panel. Thank you, Stephanie. Thank you, Dr. Kelly Johnson. I know you're not, Dr. Johnson and Dr. Ina Park are not on it any longer, but thank you so much for your time. And this was very exciting, and we thank you all for joining us today. Within 24 hours, you should receive a link to an evaluation from elizabeth.olson@ucsf.edu. Please complete the post-course survey evaluation by November 12th, and that is needed in order to receive CME credit for today's webinar. And then, like I mentioned, in 2 weeks, you'll receive a recording of the webinar, copy of the slides, and a document addressing all of the unanswered questions from today's session. So thank you. And if you do have any questions, whether they be clinical or training assistance questions, you can direct those my way to allison.decker@sfdph.org. If you have administrative questions or anything about your registration or CME, you can follow up with elizabeth.olson@ucsf.edu. Thank you very much and have a great rest of your afternoon.
Thank you, Allison. Thank you, panelists, and thank you everyone for coming.